Yeah, good evening, doctors. We are live now.
Yeah,
S-
thank you. A very warm welcome to the 220th episode of the Happy Learning Masterclass webinar series. This is in association with the Delhi OBGYN Society, and the theme for today's webinar is stillbirth, which is a matter of concern. Thank you, Dr. Deepika, for taking the efforts to get everybody from Delhi on board today. And we have very important speakers, Dr. Aparna Sharma Madam, Dr. Upma Saxena Madam, and our esteemed moderators who will be covering the etiopathogenesis and management of stillbirth, which is a nightmare for every obstetrician. The program director for today's webinar is none other than Dr. MC Patel, sir. Sir, thank you for the opportunity for all of us to coordinate this program. Let us invoke the blessings of Lord Almighty before we begin the webinar. Can we have the inauguration slide, please? Thank you. It is my proud privilege to introduce Dr. MC Patel, sir. He has been the past vice president of Foxy, a senior medical legal consultant who has been the most approachable all across India. He has been the past president of the Ahmedabad OBGYN Society, IMA Ahmedabad, and the organizing chairperson of the Vivekanand NMO. Sir has been actively even working in the Northeast district since the past 33 years, every year operating in the most rural areas of the Northeast. We welcome you, sir, and I request you to please welcome our August gathering today. Patel, sir?
Only 1 minute.
Yes, sir.
Yes. It gives me immense pleasure to welcome you all on 220th episode of Happy Learning Masterclass. And today we are going to discuss with all the learned gynecologists from Delhi. I welcome Dr. Alka Kriplani Madam. She has kindly consented to be chief guest to bless the webinar. She is, of course, always with me in any of my academic activity. Thank you for the same. I also welcome two guests of honor, Dr. Pratima Mittal and Dr. Ashok Kumar. Both have kindly consented to be guest of honor to bless the webinar. So welcome Dr. Pratima Mittal and Dr. Ashok Kumar. I also welcome all learned chairperson, Dr. Deepa Gupta Madam, Dr. Kiran Chabra Madam, and Seema Prakash Madam. They are going to chair a very interesting session to be covered by Dr. Aparna Sharma, Etiology of Stillbirth. I also welcome one more set of chairperson, Dr. Vandana Gupta Madam, Dr. Anita Rajuria Madam, and Dr. Sandeep Talwar Madam. They are going to chair a very important session of management of stillbirth to be taken by Dr. Upma Saxena Madam. I also welcome one more set of chairperson, Dr. Panchampreet Kaur, Dr. Preeti Gaur Madam, and Dr. Renu Chawla Madam. They are going to chair a session IUFD, Aftermath and Beyond, which will be covered by me only. I also welcome learned moderator, Dr. Jaya Chawla Madam. She is going to moderate very interesting panel about prevention of stillbirth. And as an expert, Dr. Neelam Agarwal, founder president of Stillbirth Society of India, and Professor Tamkin Khan Madam, founder secretary of Stillbirth Society of India. They are going to give their inputs during panel discussion. I also welcome all the knowledge panelists, Dr. Manisha Kumar, Dr. Ratna Viswas, Dr. Rachna Agarwal Madam, Dr. Veronica Arora Madam, Dr. Sangeeta Gupta Madam, Dr. Sumitra Bachani madam and Sangeeta Gupta madam. And I also welcome my own team, Dr. Monica Umardan, she is convener for this series, Dr. Monica Gupta, Dr. Deepika Logani, Dr. Nivedita Datta, Dr. Satabdi Day, and Dr. Megha Kamlapurkar. They are coordinating this webinar series. I also put in record sincere efforts on part of Dr. Deepika Logani for this webinar. She has kindly helped me to execute this webinar and to plan this webinar. Thank you, Deepika, for the same. So, and all the delegates who have joined this webinar, in era of COVID-19, when physical meetings were not possible, I started this series, and at that time, my aim was to just to say hello to all Foxian friends and to discuss very focused topic and to update our knowledge as far as OBGYN practice is concerned. An ultimate goal was to check maternal mortality and infant mortality, because as such, government and WHO has given us a target by 2030, our maternal mortality rate should be less than 67 and infant mortality rate should be less than 12. Of course, there are few states, particularly in southern India, they have already achieved this goal. But even there are few states, including northeast states and MP and etc. Still, they are near 200 as far as maternal mortality rate is concerned. And that is why it's a matter of concern for us as an obstetrician, because we are the person to take care of all this part. So if we go join hand with Government of India, federation like FOXI, IMA, and all the Foxian friends, obstetrician friends, and other friends who are practicing in remote rural India, and if we take care of all this, then we can check maternal mortality. With this aim, we discuss very important focus topic every Tuesday. So welcoming you all without wasting much of your time. Thank you. Thank you very much.
Thank you, sir. You have taught us the three words: to be perfect, to be passionate about the work, and with consistency, we have been doing it so that we reached to 220th episode today. We have none other than Dr. Alka Kripalani, madam, as our chief guest today. She has been the past president of FOXI, the past president of the Gynecological Endocrine Society of India, and she is still the president, the past president of Delhi Gynecological Endoscopic Society, and the president of AOGD. She has been the editor of the Asian Journal of
Monica
OBGYN.
ji, I keep
Yes,
coming in
ma'am.
this forum 100 times. So thank
Yes,
you
ma'am.
very much, Dr. Monica, for
Yes.
kind introduction. And today's topic, stillbirth. I think none other than our dear friend Dr. MC Patel. Nobody is better than him, because whatever you may see, Monica, you will agree with me. In the best of centers, in the best of place, stillbirth happens to the best of VIP, and it creates such a difficult situation because nobody expects it, and it has so many issues why it happens. More important, what you are supposed to do, because stillbirth is the most dreaded complication in every obstetrician's career, and no one is better than Dr. Patel to tell how to counsel and how to handle the medical legal issues. So I think today's this happy learning is going to be a great learning experience for all of us. And I really appreciate Dr. MC Patel, the way he is continuously working for medical education, taking out such pertinent topics like stillbirth, and I'm very sure he will do the best counseling regarding how medical legal issues should go, because I know so many friends where career were at stake because stillbirth happened, and it is 100%. It's not 100%, and it sometimes it happens in the best of centers. So let us see today's webinar how we all will be educated, and I would like to appreciate again Dr. Monica and Dr. Patel for this lovely topic. Thanks for the invitation.
Thank you, madam. Thank you
Namaskar,
for
ma'am.
sparing time. Of course, you are always with us in any of our academic activity. So kind of you, madam.
Thank you, sir. Thank you.
Thank you, ma'am. It was an
Namaskar,
honor to
ma'am.
share this space with you. And Now I would request Dr. Monica Gupta Madam to please introduce our guest of honor for today, Dr. Pratima Mittal Madam and Dr. Ashok Kumar sir.
Thank you, MC Patel sir and Monica, for giving me opportunity to be a part of this program. And it is my proud privilege to introduce Dr. Pratima Mittal Madam, who is a Professor Emeritus and HOD of Amrita Hospital and Research Institute, Faridabad, as well as VMMC at Safdarjung Hospital. She is an honorary FRCOG from Royal College, UK in 2019 for exemplary work done in women's healthcare. She is a WHO consultant, mother and newborn project. She was a vice president in 2018, president of AOGD in 15-16, member Technical Resource Group MOHFC, Government of India for various maternal, child and adolescent health concerns. Collaborated with many WHO projects including mother and newborn care units in India, Delhi, stillbirth registry, etc. She is a member of DSMB and TAG of ICMR and SAS projects. Over to you, madam, for your kind words. Pratima ma'am.
Unmute. Thank you, Monica. Thank you for all the nice words. And thank you, Dr. MC Patel, for, considering me for this honor, this important, honor. And first of all, I would like to say that this series is really, really important. 220th series. It's a, great thing to be happening. And it's really a good academic activity, which we keeps abreast with the latest development in all the fields of obstetrics and gynecology. And coming to Dr. MC Patel, I think I have no words. He has been my, we have been together as a vice president in 2018. And since then, we have developed a special rapport with each other. I have seen him as a great philosopher, a very, very sincere man, and very knowledgeable as well as very organized. His planning, his meticulous planning is really, really important. And I wish him success for his, for his tenure. If whenever he gets the chance of becoming the president, I wish him success. He will definitely become, president. And coming to the topic, I think this topic is very close to my heart. It's a very unfortunate situation for the mother and the child both, but it's very intriguing also. We have to identify the cause. And there was no consensus in the definition, no consensus in the etiologies. And even with Dr. Neelam, who will be chairing the session later on, and Dr. Tamkeen, all of us we have done a lot of work on this topic with WHO. We had established Delhi Birth Registry in all the hospitals, and in those registry, even AIMS helped us in identifying the genetic causes and doing all the metabolic disorders, identifying those disorders, conducting postmortems. And I think still with so much work being done, still at times you feel that you have to know so much more also. And because etiology is always confusing, the management is always confusing, but still we are going ahead. And as Dr. Patel said, if we really know scientific reasons, if we really know how to manage them in a planned manner, we will be definitely able to decrease the stillbirth rate, and we will be able to reach the goals which we are planning. Thank you very much for inviting me. Thanks a lot.
Thank you, Dr. Pratima Madam, for sparing time for me. Of course, you are always with me in any of my
Sir,
activities.
आपके लिए कुछ
Thank
भी.
you. Thank you. Thank you.
Thank you, ma'am, for gracing the occasion. Our next guest of honor is none other than Ashok Kumar sir, who is the person behind the successful AICOG Delhi, which we all have attended recently. He's a director and professor at Ram Manohar Lohia Hospital, vice chair elect of ICOG in 2024, secretary ICOG in 21 to 23, president Delhi Society from 24 to 25, national corresponding editor for Jogi in 24 to 26. He has done his MD from AIMS New Delhi and PhD from Tokyo Women's Medical University. And he is an editorial member for Indian Journal of Medical Research and Archives of Gynecology and Obstetrics. His special interest is in the maternal health, and he has been awarded by Dr. Satya Paul Award in 2019 for excellence in high-risk pregnancy management. Over to you, sir. I think sir has joined. I couldn't
I
see
can't
him.
see him, ma'am. I
Nee,
can't see him.
Sir has
No,
not
Over here.
joined. I've left him a message. Sir is not answering. So I think we
no,
can go
no.
on.
We can
Maybe
have
Yes.
his blessings when he joins.
I had
Yes.
a word with him. He will join, but till we can continue with our
Yes, sir.
scientific, and
Academic program.
whenever he joins, we will have blessings from him at that
Yes.
time.
Yes, sir. Yes, sir. ठीक है.
Thank you, Monica ma'am. And with this, I declare that the inauguration is now over. And sir, with your permission, can we start with the
Oh yes,
academic
oh
session?
yes, oh yes,
Yes.
oh yes.
Before I start with the academic session, because the maximum crowd is right now, I would request all of you to please support Dr. MC Patel sir in his candidature as the president Foxy for the year 2026. And we now request our next coordinator, Dr. Deepika madam, to please start with the first session, which will be taken by Dr. Aparna Sharma madam.
So, thank you, Dr. Monica. And I wish to thank Dr. MC Patel and Dr. Monica for giving us the opportunity of coordinating this session. And welcome to all my seniors, colleagues, and friends from Delhi, because today's session is with Delhi. So I will start by introducing the chairpersons for session 1. And it is my pleasure to introduce our first chairperson, Dr. Deepa Gupta. Ma'am is the governing council member of ICOG. She is the chairperson of the Community Health and Public Awareness Committee of AOGD and a member of the Safe Motherhood Committee of FOXY. Madam also serves as the vice president of the Indian Medical Association.
It's okay, Dr. Deepika. Thank you.
And is the director of Muskan Clinic. Welcome, ma'am. Our second chairperson for this session is Dr. Kiran Chhabra, ma'am. Ma'am is a senior consultant, Obs and Gynae, and director of Chhabra Medicare Center, Pitampura. Ma'am is the president of Delhi Gynecologist Forum, Northwest, and executive member of FOXY Food
Okay,
Drugs and
Deepika.
Medico-Surgical Equipment Committee.
Deepika, one line will be okay for everybody. I think that saves time.
Yeah. So welcome, ma'am. And our third chairperson is Dr. Seema Prakash, ma'am. Ma'am is a senior consultant, Obs and Gynae at UCMS and GTB Hospital, a president of Nama Foundation and vice chairperson of ISA.
Thank you.
Ma'am, welcome. We welcome you to as our chairpersons. And
Yeah, thank you so
honored
much,
by your
Deepika.
presence. Can I request Dr. Deepa Gupta, ma'am, to please introduce our speaker for the session, who's first session, who's none other than Dr. K. Aparna Sharma, ma'am.
Dr. Ashok sir has also joined, Deepika.
अच्छा तो फिर सर डॉक्टर अशोक कुमार सर से ब्लेसिंग्स ले लेते हैं
Oh
सर.
yes, yes, yes.
Yes. So sir, can we request you to give your blessings, sir, to our webinar? Thank you, sir, for joining.
Welcome, Dr. Ashok Kumar. You had been already introduced before you joined. And thank you for sparing time for us. Of course, you are always with me in any of my academic activity. Thank you. Yes, over to you, Ashok Kumar.
Good evening, all. Dr. Patel, good evening to you. And as you have told, yes, I am there. आपको पता ही है कि आपके साथ हैं हमेशा.
Yes.
I again wish you a success in all your future endeavors, and hope to see some changes at the top now. And
Thank you, sir. Thank you.
wishing you success in all these series of happy learning, and in future also in your multiple places you are going and trying to arrange all these CMEs and webinars. And obviously the concept of holding webinar or CMA is to update and exchange knowledge to each other, and we try to see that what is happening around the world also. And this is a form of learning. Again, we learn from each other and we follow each other practices, and we try to see what all is being done by fellow colleagues also. So this is a good way of learning again, and we update our knowledge in day-to-day practice. So thank you very much for arranging all these type of programs. And it is a long series, I think, and we all know that you have done earlier also. It is a long series which keeps on going on every week or every fortnight. So thank you very much, and thank you also for inviting me and giving me opportunity to interact with all of you. And without taking much more time, wishing you all the success and wishing all the participants and the faculty a happy learning. Thank you very much.
Thank you. Thank you, Ashok Kumar, for sparing time.
Thank you, sir.
Thank you, sir, for the kind words. Over to you, Deepika, now.
So over, Dr. Deepa, please,
Yeah,
could you introduce our speaker for the first session?
yeah. Thank you, Dr. Deepika, for the kind introduction. And many, many congratulations and best wishes to Dr. MC Patel, sir. Sir, our speaker for this session is Dr. Aparna Sharma. She's professor and unit head, Department of Obstetrics and Gynecology at AIIMS, New Delhi. She is a fetal medicine specialist with expertise in fetal interventions and the vice president of the Society of Fetal Medicine 2026 to 228. She is a deeply committed person to quality improvement, respectful maternity care, and simulation-based medical education.
Thank you,
And
Dr.
Madam was the organizing secretary of the famous AICOG 2026, which was conducted with exceptional academic excellence and remarkable organizational success. Now, she'll be speaking on the topic etiology of stillbirth. We welcome you, Dr. Aparna. Over to you.
Thank you, Dr. Deepa, and thank you, Dr. Patel, sir, for giving me this opportunity. So we'll be speaking briefly about the etiology and like a little bit of an overview of stillbirths. So when we talk about stillbirth, the weight that it carries to the mother, to the family, to the future pregnancies. So I think this is not just an event which happens at that time, but it is something that stays with the family forever. So this is something that has a huge implication. And a baby is stillborn every 16 seconds. And in every country, the risk of stillborn is highest among the most vulnerable population. So this is something that is really needs attention, and hence, I mean, there's a lot of effort going on in this direction. But first of all, we need to define stillbirth, and that is where the uniformity of definition needs to come. So while WHO defines it as more than 1 kg or more than 28 weeks, but effectively the definition would be whenever after the period of fetal viability, which is more than 500 grams or more than 22 weeks completed period of gestation. So various organizations have defined stillbirth by weight and by period of gestation. So for overall comparison and international comparison, a birth weight of more than 1 kg or more than 28 weeks is taken. But for all practical purposes, and even for places which offer early resuscitation or the survival, more than 22 weeks and more than 500 grams is something which is for statistics and registration. And at most of the places, this is the definition that is taken into account. So there are risk factors. We know that there could be antepartum risk factors, there could be intrapartum asphyxia, there could be intrapartum unexplained or unclassified. So when we talk about that, so the recent evidence which talks about what is the contribution of various factors and which increases the risk of stillbirth. So in this situation, if you look at it, increasing maternal age. So this is the heat map of the various obstetric risk factors when you talk about it. So increasing maternal age, and especially if it is more than 40, a previous history of stillbirth, a fetal growth restriction in the baby, oligohydramnios, a late term pregnancy of more than 41 weeks, decreased fetal movement, and ART pregnancy and IVF pregnancy. So this is essentially, so the darker the color, the greater the risk is of having a stillbirth in that pregnancy. So if there's a small baby or if it's a late term pregnancy, we must expect that, okay, the risk of stillbirth is definitely more and this pregnancy needs more monitoring. Similarly, if you look at the medical conditions, you have diabetes and increasing risk factors from diet to insulin, hypertension, severe hypertension, preeclampsia, non-severe. Even non-severe has a increased risk of stillbirth. Preeclampsia severe has a increased risk of stillbirth. SLE, any immunological disorders, has an increased risk. Similarly, renal disconditions in pregnancy, cholestasis of pregnancy also has an increased risk. So in terms of severity, if you look at it, immunological disorders with a background of renal condition would be at highest risk of stillbirth in terms of medical conditions. But of course, obesity, smoking, all of them do contribute to increased risk of stillbirth. So can we predict stillbirth? So in terms of an aggregate, what is the odds ratio? So if you have a mother who's more than 40, you have 1.8. The odds ratio is 1 point, almost twice an increased risk of stillbirth. Similarly, increasing BMI will increase the risk of stillbirth. Smoking, preterm antenatal care, if it is inadequate, there is an increased risk of stillbirth. Antepartum hemorrhage, and these are some of the things which can be modified. So an inadequate antenatal care would increase the risk of stillbirth by 2.5 times. Antepartum hemorrhage, if present, increases the risk of stillbirth. So again, the other side is, what are the good practices which have been evidence based and which have shown to decrease the risk of stillbirth? Is if you are actually decreasing the risk of stillbirth is like, the sleeping on the right side, decrease fetal movements. If you have a fetal movement frequency which is reported by the mother, which is actually good. Again, vigorous fetal movements, they have shown to decrease the risk of stillbirth as an evidence based. So to actually look at a summary of the etiology of stillbirth, we know it is maternal placental fetal infection or unexplained. Within the maternal causes, we have looked at various causes, including uncontrolled thyroid, ICP, diabetes, autoimmune renal, APLA, previous fetal growth restrictions, substance abuse, and an advanced maternal age. Among the fetal causes, you can have RH isoimmunizations, you can have genetic problems, chromosomal congenital malformation, complications of multifetal gestations, fetal hydrops, or FGR. Among the placental causes, you could have placental abruption, placenta previa, uteroplacental insufficiency. Now, the placental causes, so to say, are the fallout of the maternal causes in most of the situations like uteroplacental insufficiency. So if the mother has hypertension, the placenta will reflect uteroplacental insufficiency. So it's like now what we call as the great obstetric syndrome, where the placenta is a medium of what is happening to the mother, and it is reflecting onto the baby as growth restriction and eventually stillbirth. And placental pathology is reflected as chronic velitis, massive perivenous fibrin deposition. Infections, they have been implicated in a big way, but again, at the end of the day, what are we able to do about it? That remains questionable. But yes, various bacterial infection, viral infections, and parasitic infections have been associated with stillbirth. Transplacental infections like CMV, syphilis, and parvovirus, and the TORCH group of infections, they are also known to cause the stillbirths. Similarly, ascending infections following preterm rupture of membranes and prolonged leaking could lead to an ascending infection and stillbirth in the fetuses. But of course, there would definitely be certain proportion which would remain unexplained and which could not be identified to any maternal, fetal, or placental, and it is definitely common near term. So any early preterms, usually you would find a cause, but term preterm unexplained are more common. Intrapartum causes of stillbirth, definitely another big proportion where you have the causes which you have identified during labor, and that could happen from in terms of placental abruption, obstructed labor, malpresentation, uterine rupture, fetal distress, and other unspecified causes. So if you look at the etiology, can you classify them into any particular system? So there have been various attempts to do that, but the most commonly used is the WHO ICD-10. The recode was the relevant condition at death, which tried to classify them as the fetus, umbilical cord, placenta, amniotic fluid, the uterus, mother, intrapartum, trauma, and unclassified. So this was given by Cardosi in 2005. But of course, the most important one remains the ICD-PM.
Aparna, just a moment, please. Dr. Aparna, sorry to interrupt. Somebody
Yes.
is joined with two sets, so there's a huge amount of echo going on.
Yes. Is it better now?
Yes, ma'am. अब ठीक है.
Yes, it is now better.
Yes.
Okay. So when we talk about ICD-PM, we have to understand that it is divided into, so this also actually kind of streamlines the way we think. Is it an antepartum cause? Is it an intrapartum cause? And is there an associated maternal condition? So if you talk about the antenatal cause, then we can have, sorry. So if you talk about an antepartum cause, then you could have A1 is congenital malformation, infection, antepartum hypoxia, or other disorders, and disorders related to. So most commonly, if you have an FGR, it would be A5 related to fetal growth. So when we think about it in this way, this helps us to actually streamline our thought process and find investigations and try to find the cause accordingly. And if you have an intrapartum, are there congenital malformation, birth trauma, acute event, infection, and other unspecified? So these are the ICD-PM system where you have to classify them as antepartum, intrapartum, or a maternal condition. Additionally, you make a table like this where you have A1 to A6, but concomitantly you have M1 to M5 also. So when you have A1 to A6 and M1 to M5, then you could have an infection or a congenital malformation with a background of maternal, medical or surgical condition. So you know that there could be two contributing factors which are leading to, suppose I generally have patients of, I could have patients of RH isoimmunized pregnancy with a maternal antiphospholipid antibody syndrome. I've had patients like that and they've had an IUD. So I don't know if the baby died because of anemia or the APLA. So I've had patients like that, and those are the situations in which a placental biopsy can help, an autopsy can help. So I need to look into the cause more like that. So now that we've covered a bit about the general etiology, let's quickly go through some of the case studies and see how the various causes result in stillbirths. So this lady, 34-year-old, third gravida, one abortion, diabetes with over diabetes in pregnancy, continuous infusion, high doses, A24, A30, I12, A20, I24, gestational hypertension. So she's high diabetic, gestational hypertension, controlled on labetalol, came at 37 weeks and 5 days with leaking and detected to have IUD. Blood sugar ranges 200 to 300. You almost feel like, okay, she asked for it, right? But still, delivered a 2830 macerated baby. So stillbirth in diabetes, of course, you know it can happen. And placental vasculopathy can lead to IUD. You can have fetal hyperglycemia, hyperinsulinemia, chronic hypoxia, or a sudden maternal hypoglycemia can lead to stillbirth. So it is our job to say that you are at high risk of stillbirth. Please keep coming for follow-up. Again, perinatal outcomes, IADPSG versus RV missing. So I know we all are DIPSI followers. I know we all do DIPSI, but are we missing out more diabetics by doing a DIPSI versus doing an IADPSG? Again, this is a debate for some time else, but is more diagnosis the better? That's a question that I will leave you with. But this is a protocol that we follow, that we do follow the IADPSG protocol and screen everybody with a fasting and PP in the first trimester, and high risk if GTT, if high risk, and later on we do a 24-hour GTT of two fasting and 2 hour. But then again, there's a concept of early GTT which is coming in to detect more. So more diabetics even in the early pregnancy, and don't wait for 24 weeks. So those are questions which might help to detect more diabetics and prevent more stillbirths. But of course, if you have diabetes, you need to follow them with an ultrasound growth, uncontrolled on diet, NST Manning weekly. Pre-gestational diabetes, uncontrolled, we need to deliver them early at 38 weeks. So we generally deliver them at 38. If they are uncontrolled, even 36 and 37 weeks. So I think timing of delivery is extremely important. Signs of placental deterioration should be explained to mother, including decreased movement, hypoglycemia, slowed growth. Important to have a close contact with the maternity team. So this is the axiom 1 for stillbirths, universal screening for diabetes, heightened fetal surveillance in women with diabetes, and timing of delivery is crucial. Case study 2, chronic hypertensive, 15 weeks, diagnosed with early onset FGR, no anomaly, genetic workup normal, REDF at 28 weeks, IUD at 31 weeks, 675 grams macerated. Uteroplacental insufficiency, can we predict, can we prevent? Again, aspirin in women who are not at high risk of preeclampsia, should we be started? Again, it's a bit of a controversy, but it has been seen that in the studies in whom aspirin has been started, there is a lower risk of stillbirth. So yes, aspirin does prevent stillbirth, but then the screening protocol is still that in women who are at high risk of preeclampsia, if you start aspirin, the risk of stillbirth is lower. And we still would like to give aspirin based preferably on all the parameters, including maternal factor, uterine artery Doppler, and PLGF. And we give a dose of aspirin before 16 weeks in a dose of 150 milligram, because that is what the evidence says. So our Axiom 2 will be screening for placental disorders in early pregnancy, to be started preferably at less than 16 weeks, with a complete history plus blood pressure plus uterine artery Doppler and PLGF screening. The next case, primi gravida, uneven full pregnancy, leaking per vaginum at 34 weeks, presented to emerge 5 hours later, detected to have IUD, retroplacental clots with a blood pressure of 160 by 100, 1470 grams fresh stillbirth with 200 cc of retroplacental clot, primi gravida abruption. Can it be thrombophilia? Can we predict? Can we prevent? Again, a preterm delivery, pregnancy-related morbidity leading to abruption at less than 34 weeks of pregnancy, we must screen for thrombophilia. And in such situations, in the next pregnancy, there could be a chance of prevention of stillbirth, giving heparin and low molecular weight heparin and aspirin. So again, stillbirths after 24 weeks are more strongly associated with various thrombophilias. So screen for thrombophilia in women with previous adverse outcomes, and women with thrombophilias to be started with aspirin and heparin with strict maternal and fetal monitoring. Now, can sleep positioning predispose to stillbirth? So there has been an association with increased risk of stillbirth in women with supine positioning when falling asleep, and as compared to those who fall in left lateral. So advise pregnant women to go to sleep on their slide for any episode of sleep during in their third trimester, even at night, day sleeps, or after nighttime awakenings. What about the perceived alteration of fetal activity? And I think this is something that we all worry about. Is it associated with increased risk of stillbirth? So the AFFIRM study said that the RFM care package did not reduce the stillbirth, did not reduce the risk. And now we called something which is called as mind fetalness. That means you be mindful of your fetal movement, and it decreased the risk of cesarean section and fewer children born with small for gestational age. So if you have a history of decreased fetal movement and the fetal heart is heard and the CTG is normal, then you do an ultrasound, and if that is normal, then you need to reassure. But if any of these things are abnormal, then you need to take action accordingly. So the axiom is no formal fetal movement count, but please listen to the woman if she says that there is some change in fetal movement, because this is called the mind fetalness. And women in reduced fetal movement look for viability, CTG, ultrasound, FGR, oligohydramnios, and Doppler abnormality. Reassure if normal. RFM after reduced fetal movement after 39 weeks, kindly deliver the patient. So this is again, please get to know your fetal movements. Be aware of your baby's fetal movements. Another case study scenario 6 is a woman who's 36 weeks, itching in palms and sole, reduced fetal movements. This lady had recurrent IUD to previous 3 pregnancies, 2 had IUDs and 1 had abortion. And 4 pregnancies had IUD. In the pregnancy, she was booked at AIIMS. All the results were normal, but her bile acids are 106. So again, monitored. So if you have a woman with a bile acid of 106, she would be severe IHCP, definitely has a fetal effect of IUD and stillbirth, and would need severe, very, very strict fetal monitoring, twice weekly biophysical profile, fetal monitoring count, or be mindful of the fetal movement, LFT and bile acids, and timing of delivery. If it is more than 100, then definitely we deliver around 36 weeks. But beyond that, if it is less than 100, maybe up to 38 weeks, we will go. But any value more than 100, we will deliver. So again, third trimester ultrasound. Case study 7, most important. And if you looked at the heat map, one of the most important causes of late term stillbirth is fetal growth restriction, late onset fetal growth restriction. So in the third trimester, look for the third trimester scan, look for placenta, fetus, biometry, fetal growth, amniotic fluid, liquor, and anatomy. So look at the placenta. In that cystic placenta, you could have placenta previa, vasa previa. All of these things could be abnormal location of the cord, placental calcification. So placenta is an important part. Umbilical cord accessions like vasa previa may lead to sudden bleeding and stillbirth. Sometimes umbilical cord thrombosis, coiling collapse, very rare causes, but yes, it can happen. Nuchal cord, we normally do not report nuchal cord, do not influence clinical management. Nuchal cord is not necessary at the time. Nuchal cord means cord around neck. So that in itself is not a cause of stillbirth, but a true knot of cord could be something which can lead to stillbirth, but that's not something that you can detect on ultrasound. Velamentous insertion of cord again could be leading to several perinatal outcomes, including stillbirth. This was a case of true knot of cord that we reported. However, this baby's outcome was all right. Again, oligohydramnios. So we know that over the years, we have reduced the significance of oligohydramnios for increasing the monitoring and not timing of delivery. Please remember what I'm also trying to say here is that oligohydramnios will not lead me to deliver this baby preterm. Oligohydramnios only means that I will take this pregnancy up to 37 weeks and deliver, but I will monitor this more because it associated with worse fetal and maternal outcomes. So, and for oligohydramnios, a deep vertical pocket is preferred anytime over AFI. Polyhydramnios also is a dangerous sign because it is more likely to be associated with fetal abnormalities, infections, chromosomal abnormalities, and tumors. If you look at the maternal Doppler, is there any role of uterine artery Doppler? Not particularly clinically, but it's a good predictor of the fact that this lady might develop preeclampsia. Fetal Doppler, one of the most important assessments that you can do in the third trimester in a baby with impaired growth. So fetal growth, even more important than biophysical profile is fetal Doppler, but you should interpret the Doppler in the scenario of the background condition. So the last axiom is in the third trimester, look for fetal growth, Doppler, maternal and fetal, Liker, placenta, and cord. Now, is the planned delivery at 39 weeks a method to reduce stillbirth? Now, we all know ARRIVE trial, which said that if you plan delivery at 39 weeks, it decreases stillbirth. Now, it may not be true for primary deliveries. I mean, it has to be taken in the context of how you are conducting the inductions and delivery. But in women at high risk of stillbirth, women who've had previous stillbirths, women who are, say, having an autoimmune disorder or having a background risk, a cautious and considered induction at 39 weeks can marginally improve the perinatal outcomes. And yes, it would depend on a shared decision making. So, the etiological consequences of evidence would be that periconceptional folic acid prevent malaria, detect FGR, reduce postterm pregnancies, detect hypertensive and diabetes, skilled attendant at birth, available of basic emergency and obstetric care, availability of comprehensive emergency obstetric care are the guidelines to improve stillbirth. So with this, I would like to conclude my talk here. But before that, I would just like to say that there was this man who was walking along the beach with a lot of starfishes, and a young boy was picking the starfish and throwing them one by one. The old man said that there are thousands of starfishes, and why are you throwing each of them back? There are so many of them, you're not making any difference. The boy listened to them politely and still threw the next one back, and he said, I made a difference to that one. So that is what it means, that even if you save one baby, that is the difference you're making because each baby counts. So thank you very much. And if there are any questions, I'll be happy to answer.
So,
Yeah, very nicely covered, Dr. Deepika. I really want to appreciate your talk, and you have covered
almost each and every aspect of this subject. And it was very comprehensive and very clear. The message has been delivered very beautifully. And the way you presented case wise was really nice. That, it is so easy for everyone to remember each and everything. Like we all have seen lot of high risk cases, one patient with 3, 4, 5, 6 complication, all the high risk pregnancies we see day in and day out in our high risk labor room. But the thing is, we must realize that how to save this complication of stillbirth. So our residents need to know that where they have to intervene, at what time, at what gestation, and what is the importance of all these day-to-day activities. Like if we tell the patient about DFMC, what is the importance of DFMC? What is the importance of CTG, ultrasound, diagnosing placental disorders? What is like medical disorders can do to the woman and her baby? So these are very important, and you have really beautifully covered the topic. And I must congratulate for the same to you. Thank you so much for such a wonderful talk.
Dr. Aparna, Dr. Aparna, your talk was really excellent. Very crisp, point by point. You explained each and everything. And what we get to know from this is that prevention is better than cure. Secondly, we have to find out, or we have to mark the red flags when we are seeing the patients from the very beginning. And these red flags can be like severe this headache, patient comes with pain abdomen, patient comes with bleeding belly, or patient comes to you with decreased fetal movements. So we have to point out these patients, and we have to give them very high risk surveillance in such cases, like NST, Doppler, the biophysical profile, and timely delivery we have to do. We have to also prevent the delay of C-section whenever we see anything on CTG monitoring or during internatal period. So thank you very much for giving us such an insightful talk on etiology of stillbirth along with the cases you have presented. Thank you so much, Dr. Aparna.
Thank you.
Dr. Aparna, it was an absolute mesmerizing talk. Absolute.
True.
Thank you.
Yeah.
Thank you.
And thank you, Dr. Deepika and Dr. Patel, for giving us this opportunity.
Thank you.
I'm really
Thank
thankful
you.
to you. Yeah.
We are honored to have you. Over to Dr. Nivedita for the next session. And thank you, Dr. Aparna. Thank you. Thank you so much.
Thank you.
Thank you, Deepika.
I would like to thank the Happy Learning series headed by Dr. MC Patel sir and coordinated by Dr. Monica for bringing us this excellent deliberation. Dr. Aparna, it was just fantastic. Moving on to session 2, I thank the chairpersons of session 1 as well as Dr. Aparna. The session 2, we have another important session on management of stillbirth. And to chair this session, we have Dr. Vandana Gupta, Dr. Anita Rajoria, and Dr. Sandeep Talwar. Dr. Vandana Gupta is a senior consultant, OBS and Gynae. She is the coordinator of Delhi Gynae Forum, chairperson, GDM and stillbirth prevention of Delhi Gynae Forum.
Thank you, Dr. Nivedita. Let's move on.
Okay. Welcome, Dr. Vandana, and we hope to have great inputs from you after this talk. Dr. Anita Rajoria, another very dear person and someone who's always smiling. She's the president, ISOPAP Delhi Governing Council, member ICOG, HOD, GNO at Hejawar Arogya Sansthan, Government of NCT Delhi. She's a member of number of bodies like AOFOG, FOXY, DGF, NARCHI, IMA, DMA, ISAR, ISPAT, etc. with multiple awards and publication in national and international journals.
Thank you. Thank you so much, dear. Pleasure being here. Yes.
How are you, Dr. Anita? Good evening.
Thank you.
The third chairperson in the series, Dr. Sandeep Talwar. She's an infertility specialist. Right up this stream, I think, because when we think of stillbirths, we begin from a management of infertility and early pregnancies. So, an infertility specialist, she's a DNB teacher and trainer for infertility and reproductive medicine for the fellow gynecologist. She's a senior consultant at Nova Southern Fertility and IVF Center. And you can see from her CV multiple achievements, awards, and publications in national and international journals. She's joined the IVF unit in Sir Gangaram Hospital at Delhi and was actively involved in various activities that included a plethora of academic and technical meetings.
Thank you
Welcome
so
all
much.
chairpersons.
Thank you
all
so much.
chairpersons.
Thank you for the
Thank you,
kind
thank you.
introduction. Thank you so much.
And I would request any one of the chairpersons to please introduce our beloved speaker for this session, Dr. Upma Saxena.
My dear friends, thank you, MC Patel sir, for involving all of us. It is my proud privilege to, introduce my own dear friend, Dr. Upma Saxena. She's a very great academician. She's in charge fetal medicine and genetic clinic. She's looking after at Safdarjung Hospital, and she's currently the chairperson, fetal medicine and genetics subcommittee, AOGD.
I think Dr. Anita, we can start with our talk.
Let
Thanks.
me just finish 3-4 sentences about
Okay.
you. Governing Council member, ICOG, and Executive Committee member of Society of Fetal Medicine, Delhi chapter. Over to you, dear Upma. Upma will tell us now how to, stillbirth has happened, how to deal with the patient now. Over
Thanks
to
a
you.
lot, Dr. Anita, for the very kind words. Can I share now?
Yeah, please share.
Can you see my slides?
They are coming. Yeah. Make it full screen.
Yeah, I made it full screen.
Yeah. Perfect.
So, good evening, respected chairperson and dear friends and colleagues. At the outset, I want to thank Dr. MC Patel for giving me this opportunity. I will be talking about management of stillbirth. So, we all know that stillbirth is a neglected tragedy, a global health problem. And WHO and ICD-10, which Dr. Aparna has already told us, define stillbirth as late fetal death occurring after 28 weeks of gestation, or when the birth weight is more than 1,000 grams, or when the body length is more than 35 centimeters. So out of these, gestational age is most accurate. So dating of pregnancy is very important before we label a baby as stillborn. So we also know that stillborn are either intrapartum or fresh stillbirth, or antepartum or macerated stillbirth. This is important because this classification helps in identifying the cause and the prevention strategies. So the ICD-10 classification, which we just been told by Dr. Aparna, it highlights the linkage between the antepartum and the intrapartum causes of stillbirth and the maternal condition. So every stillbirth we have to label as ICD-10, which group it belongs. So grouping is very important. So coming to the management of stillbirth, both ACOG and Society for Maternal-Fetal Medicine in 2025 have given a joint consensus statement on the management of stillbirth. It is a continuous pathway, and the main components are diagnosis, delivery options, investigations, bereavement support, preconception care, and care in subsequent pregnancy. So the principle of management includes before delivery is confirming the diagnosis and discussing delivery option. And after the delivery of the baby, we have to examine the baby, placenta and the cord, and send for fetal autopsy, investigate the underlying cause and determine the recurrence risk for future pregnancy, and we have to provide bereavement care. So whenever a mother comes with loss of fetal movement, we have to confirm the stillbirth by real-time ultrasonography. And if couple wishes, we should take a second opinion. Usually after ultrasound diagnosis, there may be passive fetal movement. So a repeat scan can be offered to the mother. Auscultation and CTG should not be used to diagnose stillbirth. So we should use this spikes protocol for breaking the bad news. So S is for setting. So the place we counsel the parents. Then P is the perception, both by the obstetrician and by the women. Then we have to invite women to ask questions, and we have to provide her medical knowledge, and we have to provide emotional support, explain to her. We have to chalk out future strategy and summarize. A good, honest, clear, and kind communication improves trust in doctor and hospital, acceptance of investigations and autopsy, engagement in follow-up and future pregnancy planning, and also reduction in medical legal issues. Whenever a stillbirth occurs, in case the mother is unstable, there is abruption, preeclampsia, rupture membrane, infection, then we have to go for immediate induction. In case the mother is stable and willing for expectant management, then we can go for coagulation profile, platelet count, and fibrinogen level 5 weekly, and the vaginal delivery is preferred, and cesarean should be done only for maternal indication. So in case of an unscarred uterus, the first line intervention is mifepristone 200 milligram, 24 to 48 hours prior to misoprostol. The mifepristone decreases labor duration by 7 hours, and misoprostol is preferred over PGE2 for similar, as it has similar efficacy, safety, and at a lower cost. The usual dose of misoprostol after 28 weeks is 50 microgram 4 to 6 hours. And labor should be conducted in an area separate from where the live ones are being born, provided obstetric emergency care is available. So as you can see, the FOXY, ICOG, GCPR, and RCOG, all they say the dose is around 25 to 50 microgram 4 to 6 hourly after 28 weeks. If there is prior one section, then no specific regime is recommended. If more than 2 cesarean, then induction safety is unknown. So why evaluate to identify the cause of stillbirth? This is to move away from the unexplained cause, improve clinical practice, enable accurate audit and surveillance, guide parental counseling, prevent recurrence, and help in grief resolution. So every stillbirth needs a diagnosis, as every parent needs answer for the loss of their unborn child. Coming to the evaluation, a detailed family history is taken for recurrent spontaneous abortion, venous thromboembolism, congenital anomaly or chromosomal abnormality, hereditary condition or syndrome, and consanguinity. And in the maternal history, we have to take history of previous venous thromboembolism, diabetes, chronic hypertension, SLE, epilepsy, anemia, heart disease, and substance abuse. In the obstetric history, we have to ask for recurrent miscarriage, previous child with anomaly, hereditary condition, or FGR, previous gestational hypertensive disorder, pregnancy, GDM, placental abruption, or fetal demise. So according to FOXY, ICOG, GCPR guidelines, the basic core investigation which should be done on mother should include a CBC, RFT, and LFT for preeclampsia, thyroid function for diagnosing hyper or hypothyroidism, bile acid for IHCP, blood sugar and HbA1c for GDM, blood doping and ICT for RH incompatibility, Clohel-Bitke test for feto-maternal hemorrhage, and these all should be done as soon as possible. In case we are suspecting DIC, then we have to do coagulation studies. And if there is FGR or hypertensive disorder of pregnancy, then we have to go for antiphospholipid antibodies, which include lupus anticoagulant, anticardiolipid antibody, and anti-beta-2 glycoprotein. This should be done 3 months after the delivery and should be repeated after 12 weeks. The external fetal examination should be done for gross defects, and photographs should be taken to look for facial dysmorphism or for parents to keep them as memories. A full or oblique partial autopsy should be done after the consent. The placenta and cord should be looked at macroscopically, and it should be sent in formalin for histopathology and in saline for chromosomal microarray or with DNA storage, because in case the women is suspected to have a monogenic disorder in the fetus, then we can go ahead and do a whole exome sequencing. Coming to the special investigations, fetal and placental swab should be done in case we are suspecting infection. Maternal anti-Rho, anti-La antibodies, if a postmortem shows that the baby has features of endomyocardial fibroelastosis or AV node calcification pointing towards autoimmune disease. Parental karyotype is indicative if there is evidence of fetal unbalanced translocation. Blood culture, midstream urine, vaginal and cervical swab when infection is suspected because the mother has presented with either fever, flu-like illness, abnormal liquor, or prolonged rupture of membrane. Maternal alloimmune antiplatelet antibodies are indicated if there is the presence of intracranial hemorrhage on postpartum in the fetus. So routine testing for inherited thrombophilia in absence of personal or family history is not recommended. Routine testing for congenital torch infection is also not recommended, and it should be done, torch infection should be done only if infection is suspected on the basis of maternal history, autopsy, or placental finding and early onset fetal growth restriction. In the current pregnancy, we have to look at the maternal age, gestational age, the stillbirth, medical condition like cholestasis, weight gain, placental abruption, abdominal trauma, preterm labor or pre-prom, gestational age at the onset of prenatal care, abnormality seen, gross abnormality seen on ultrasound, infection or chorioamnionitis. The placenta should be evaluated for viral and bacterial infection, and it may be found abnormal in almost 30% of the cases and small in preterm compared to term pregnancies. Fetal autopsy provide additional information in 30%, but if it's declined, then we should go for X-ray, ultrasound, and MRI of the fetus. The microarray is found abnormal in 8% of the babies, and the best sample for it is the amniotic fluid. In case it's not available, we can even send cord proximal to the placenta for cytogenetic testing. Clinicians should explain to the parents that a full autopsy is strongly recommended as it remains the gold standard and has the highest diagnostic yield, and there's a possibility of missing an important finding when a full autopsy is not undertaken. So fetus, we have to do the weight, the length, the head circumference, and the photographs taken are of whole body, face, extremities, palm, any other abnormality. Placenta and cord has to be examined macroscopically, and we have to send it in formalin for histopathology and in saline in for cytogenetic examination. In case parental consent is not available, then diagnosis of lethal skeletal dysplasia can be made just by doing an X-ray or infantogram. The ideal tissue for cytogenetic testing is amniotic fluid, which I've just told. But if refused or not feasible, then we can send fetal costochondral junction or patella or 1 centimeter skin biopsy from the upper fleshy part of the thigh. In case fetus is not available, we can even send 1 centimeter block from the fetal surface of the placenta below the cord insertion in saline with few drops of gentamicin, and this should be kept at room temperature and ideally be preferably processed within 48 hours. Formalin fixed tissue is not suitable for cytogenetic investigation. So why CMA? Because CMA has advantage over conventional karyotype because CMA uses DNA and does not require viable cells, which means that chromosomal abnormality can be detected even in a macerated child. The resolution of CMA is much more than the conventional karyotype, and as it shows us microdeletion and microduplication. In case a monogenic disorder is suspected based on the family history or specific phenotype, then we can send the test. It's cytogenetic testing we can do is whole exome sequencing. So including the antenatal detail, ultrasound, the cytogenetic report, and the fetal autopsy, the combined report should be formulated. And as you can see, the autopsy and the placental histology gives us the maximal yield. Then also, the parents should be counseled that a specific cause of death may not be found in approximately 50% of the cases. However, this may drop to 15% because of modern placental pathology. So unexplained often means under-investigated. So as you can see in this chart by ACOG, in case there is no clinical clue for the cause of stillbirth or there is FGR or hypertensive disorder, then we have to go for genetic testing, antiphospholipid antibody, fetal-maternal hemorrhage. And in case there is fetal anomaly, then we have to go for genetic testing. If there is interpartum stillbirth, there is no need for doing a genetic test. What we can do is we can send for antiphospholipid antibodies and fetal-maternal hemorrhage. And when there is preterm labor chorioamnionitis, preterm PROM, then we can go for testing, especially looking for infection. But as highlighted below, fetal autopsy and placental histopathology should be done in all cases of stillbirth. Management in subsequent pregnancy after a stillbirth, the counseling is that there is a 5-fold increased risk of stillbirth in the next pregnancy because of recurrent placental pathology or genetic condition or persistent maternal disease, and they should be delivered by a multidisciplinary team to provide continuity of physical and psychological care. So as you can see here in this chart, the risk is very high and there is previous abruption, a genetic disorder, preeclampsia, and FGR. So according to the management, the preconceptionally, all these women should be called at 6 weeks follow-up visit to assess recovery, review investigation, and counsel regarding recurrence risk in future pregnancy. Again, a detailed obstetric and medical history should be taken. We have to optimize maternal medical condition preconceptionally like chronic hypertension, diabetes mellitus, SLD, thyroid, anemia, epilepsy, cardiac disorder. We have to change modifiable factors like smoking and weight reduction in obese women. We have to tell the mother that in the next pregnancy, she is at higher risk for preterm labor, FGR, PE, and abruption. We should do antiphospholipid antibodies. Diabetes screen is must because the odds of gestational diabetes are fourfold high after an unexplained stillborn. And inherited thermophilia and genetic counseling is done only if the history suggests over it. And every time we have to support and reassure. In the first trimester, we have to do a dating ultrasound because it's very important to that they have a definite expected date of delivery because these are high-risk pregnancy. We should do first trimester combined screening. In the second trimester, an anomaly scan should be done between 18 to 22 weeks. And at this point, we should look at uterine artery Dopplers and also placental thickening with cystic spaces. In case the first trimester combined screening is not done, then we can go for quadruple test. In the third trimester, the ultrasound with Doppler looking for FGR should start at 28 weeks. The mild fetalness also should start after 28 weeks, and the fetal surveillance should start at 32 weeks or 1 to 2 weeks earlier than the previous stillbirth. Every time we have to support and reassure. So the Stillbirth Society of India says that among the preconception bundle, every pregnancy should be planned and wanted, and the chronic conditions should be optimized before the women embarks on pregnancy. Among the safe baby bundles, it emphasizes on regular antenatal checkup, healthy balanced diet, monitoring weight, and mild fetalness, which is that the women should be told that she should start receiving movements from 5 months, and she should that if the movements are this change in fetal movement, then the baby is in danger, and she should report to the doctor if there is change in the strength or the pattern of movement. She should sleep on the side, so she should not sleep supine, and she should have an institutional delivery. So this study done in 2013 shows that after 39 weeks, there is a sudden increase in the stillbirth rate. So the plan of termination of pregnancy in a woman with the previous stillborn should be charted at the beginning and should be subsequently discussed, and they should have an elective induction at 39 weeks. These women who had a prior stillbirth also have a high tendency to have postpartum depression, especially if they conceive within 12 months from an IUFD. This is because of the unresolved maternal grief resulting in disorganization of attachment with the future. Low-dose aspirin 150 milligrams started between 12 to 16 weeks and continued till 36 weeks of delivery has some benefit, especially when the stillborn is associated with placental disease. Coming to bereavement care in stillborn, this landmark Lancet paper shows the economic and psychosocial consequences of a stillbirth. So a stillbirth leads to psychological and emotional distress and isolation, increased healthcare costs, negative effect on the staff, increased risk of the family breakdown, stigma, abandonment, abuse, reduced earning, and increased healthcare expenses. So this systematic review 2015, it reported positive outcome for parents who saw or held their babies. So the Ministry of Health guidelines also have chalked out principles of bereavement care for women with stillbirth. So what we have to do is we have to reduce stigma. We have to provide respectful maternity care both to the mother and her child. We have to support women to make shared decision making. We should make every effort to investigate and identify an acceptable explanation for her stillbirth. We have to acknowledge the depth and offer appropriate emotional support, offer appropriate information. Also, we have to discuss with her about future pregnancy planning. We have to provide bereavement care by providing comprehensive and ongoing training and support to all members of the healthcare team, and autopsy should be done after informed consent. So even ACOG says that we have to individualize bereavement care. The good communication and shared decision making is very important. It emphasizes on a recognition of parenthood and memory making. So basically, this leads to actualization of the grief and slow transition of the parents' relationship with their baby from one of presence to one of memory. So recognition of parenthood is very important. We have to acknowledge the grief of the mother, individual and her family. We have to be aware of the burial, and we have to always provide ongoing emotional support. The health professional should be trained in bereavement care and should have access to self-care. So parents should be encouraged to keep baby memories, and they should have the choice of seeing and holding their baby. They should be asked to keep photograph of the baby, And memories can be kept in the form of lock of hair, hand and footprint, or a piece of cord. Coming how to prevent stillbirth due to undiagnosed FGR. First of all, it's very important to identify a small baby. Then we have to differentiate whether it's FGR or SGA. And we have to differentiate between early and late FGR and provide a stage-based management protocol. So in order to understand the stillbirth due to FGR, the placental damage in case of late onset FGR is less than 30%, while in case of early onset, it is more than 30% when the uterine artery PI is more than 95th centile, and it's almost 60 to 70% when there is absent or reversal. So in case of early FGR, because of the placental damage, there is uterine artery resistance, which lead to heart failure, so ductus venosus become abnormal. While in case of late onset FGR, the ductus venosus remains normal. So FGR and CTG abnormalities in early FGR, they occur much before the DV abnormality. And DV helps us to determine the termination before 30 weeks in case of there is absent of uterine artery waveform. So this Doppler, what we have to do is we have to balance between the iatrogenic prematurity and stillbirth in case of early onset FGR. In case of late FGR, the brain stem is affected. So CTG is affected more before the cerebro-CPR ratio on the MCA-PI. So early onset FGR leads to late stillbirth between 28 to 36 weeks, and the late onset FGR leads to term stillbirth more than 36 weeks. So SGA babies should be delivered at 38 to 39 weeks. Early FGR based on their stages, and the late FGR should be delivered ideally by induction between 37 to 38 weeks. And CTG should be the trigger for preterm delivery, not CPR. So to conclude, stillbirth is major but often preventable tragedy. Spike's protocol should be followed for breaking the bad news. Every stillbirth needs a diagnosis, as every parent needs answer for the loss of their unborn child. Bereavement care in stillbirth is of utmost importance. Placental histopathology is the key for stillbirth etiology. An autopsy should be done after informed consent. Investigating and identifying cause of stillbirth is a cornerstone of management in a woman with history of previous stillbirth. And low-dose aspirin has a role in prevention of stillbirth due to placental pathology. So these are my reference. So maternity service should be judged on how it treats its most vulnerable client. Thank you.
Thanks, Dr. Upma, for such wonderful deliberation. Really, this is a pathetic aspect that once a lady loses, and when we are, it really feels, you also, the doctor also feels very, very bad. But then your feelings and emotions have to be controlled and the patient has to be looked after. So that is our first priority. And then comes the medical aspect that nothing should be repeated in the future. And as very well described by Dr. Aparna and Dr. Upma, that every aspect of medical and obstetric reasons should be taken care of. And that really
So
makes
mother,
it very, yeah.
we
Mother,
should always find the answer for the stillbirth. That's very important for
yes,
the patient.
that is, see, the closure for the mother would come only when she finds some answer that why did I lose my baby? Every mother, because now the number of pregnancies are limited. It's not like that every woman can have 7 or 8 babies and lose 1 or 2, doesn't matter. It does matter. Everyone has only a single child or maybe 2 children.
Yeah, well
Baby
said.
counts.
Well said. It's very important to find answers. That's a very, very valid point. Everybody wants to know why this happened because it's such a big tragedy. And Upma really spoke very nicely about the psychological aspect of the whole thing. The whole family is traumatized. It's not only the woman who's traumatized, the whole family is traumatized, and they could go through a very bad psychological trauma and that kind of a trauma. So how you take care of that whole bereavement is something which is very important. And what I feel is that you should be training the new consultants as to how to give support to these women. That's a very important aspect.
Very nicely highlighted by Sonu and Dr. Vandana. Bereavement care is very, very important. And it is not only the respectful maternity care, I must say that respectful family care is now the
Yes.
word which has been given by WHO. The whole family has to get that kind of support. And it is, I think, very reassuring for the couple or the family to know that the cause was non-recurrent. So it gives them a closure and means hope, there is hope for the next pregnancy. That is very important. Very nicely highlighted, Upma. I knew the time was less, but you highlighted
I
each and
tried to
every
cover it.
important aspect.
Absolutely, absolutely.
Yeah. Thank
Thanks,
you.
Dr.
Thank you.
Patel, for giving us this opportunity to be here.
Thank you so
Yes.
much. Thank you so much.
And thank you to our dear friends Deepika and Monica Umarban.
Yeah,
Because
yeah.
it's always a pleasure
Yeah,
to
yeah.
be there.
Anything.
Absolutely.
Thank you so much.
And the master of stillbirth knowledge is here. I'll request Madam Tamkeen to make some comments about her presentation.
Thank you so much, Dr. Anita. It's great to see you after a long time, and Dr. Pratima and all people from stillbirth. I think it was very challenging to cover so much in this time, and she covered almost everything. Hardly anything was
Thank you.
left. So
Thank you. I tried to cover Society of Stillbirth guidelines
yeah,
also
and
in my
thank you
book.
for highlighting those.
Yeah.
Thank you so much.
Covered everything, Dr. Upma. Very well.
Very well covered.
Very well covered.
Thank you,
Excellent.
Deepika.
Thank you.
Thank you. So, with your permission, can we close this session and go on to the third session, sir?
Oh, yes.
Yes, sir. So
Thank
now,
you. Yeah, thank you, Dr. Upma. Brilliant deliberation on management of stillbirth. I now hand over to the next coordinator for coordinating session 3 of this challenging topic, stillbirth.
thank you, Dr. Nivedita. So I am the coordinator for this session also. So we now move on to our next session 3 of today's webinar. And it's my pleasure to introduce our esteemed chairpersons for this session. Our first chairperson for this session is Dr. Panchampreet Kaur. Madam is the assistant professor in Obs and Gynae at VFMC and VMMC and Safdarjung Hospital. She is the secretary of Delhi Gynecology Forum South and co-chairperson of the Adolescent Committee of Delhi Gynae Forum 24-25 and executive member of Endoscopy Committee and Adolescent Health Committee of AOGD. So welcome, Dr. Pancham. Our second
Thank you so much, ma'am.
second chairperson is Dr. Preeti Gaur. Madam is a senior obstetrician and gynecologist practicing in East Delhi for over 3 decades now. Ma'am is the senior vice president of IMD East Delhi branch and also serves as honorary.
It's fine. Thank you so much, Dr. Deepika. It's okay.
Okay. Our third chairperson for the session is Ma'am Dr. Renu Chawla, ma'am. Ma'am is a senior consultant obstetrician gynecologist at Kailash Deepak Hospital. Ma'am is the vice president of East Delhi Gynae Forum and past secretary of the forum and is the recipient of the prestigious APJ Abdul Kalam Appreciation Award. We welcome our chairpersons. And can I ask Dr. Preeti Gaur, ma'am, to please introduce our star speaker for the session, none other than Dr. MC Patel, sir.
Thank you so much, Dr. Deepika, for your kind introduction. And let me take the privilege to introduce our esteemed speaker for today and all my good wishes to sir as a candidate for Foxy President election. It's my honor to introduce him. Thank you so much, Dr. Patel, sir, for involving me here in this masterclass webinar. And yeah. Sir has been president of AOGS in 2010, 2011, president IMA Ahmedabad 2007, 2008, national president NMO 2016 to 2018, organizing chairperson Vivekanand NMO, conclave 2013, and he has been many community and service to his credit. On a Surgeon Red Cross Eye Bank, collected 1,000 plus IPA services, Dhanvantari Seva Yatra under NMO, government and statutory roles also he has had, PNDT and NIMC, Government of India 2015, Gujarat PNDT State Supervisory Board 2005, 2009, National Managing Body, Indian Red Cross from 2019 to 2022. Welcome, sir. We are eager to hear you, sir.
Thank you, madam, for kind word. Let me share my screen. Is it seen?
Yes, sir.
Is it seen full screen?
Yes, sir.
Full screen?
Full screen नहीं है, sir.
Full screen नहीं है?
नहीं है, sir.
नहीं.
It's long.
Sir is gone now.
सर आपकी प्रेजेंटेशन सबके लिए इम्पोर्टेंट है बिकॉज एक बार स्टिल बर्थ हो गया तो मेडिकल लीगल प्रॉब्लम्स क्या है वो सब सुनना चाहते हैं.
Only 1 minute.
यस सर.
Is it seen full screen now?
Yes, sir.
Now full screen.
Yes.
Yes.
So greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to all the faculties who have joined this webinar to boost up our interest to continue this Happy Learning Masterclass web series. And before I go to the subject, it is my humble appeal to endorse my candidature for post of President Foxy election year 2026. As far as this IUFD and stillbirth is concerned, it is a potential area as far as litigation is concerned. So usually I start any of my talk with this question: is it worth discussing? Yes. If it is yes, then why? Because IUFD, aftermath and beyond, it is a very important topic, and when something goes wrong in this area, it is a potential area as far as litigation is concerned, and we are bombarded with so many questions. Why this happened? Who is responsible for that? How you couldn't prevent it? So there are so many questions we have to answer to the relative and to the patient. And medical litigations are increasing in number constantly and steadily, and unluckily, we gynecologists rank first. And this is, of course, it is in Gujarati, but I have written in English also. As such, I have searched in Google about my illness and medicine, etc. But thought, let me have second opinion from you. So now patients are smart enough, having knowledge from Google. Of course, it is hazardous because they have not complete knowledge, but it becomes troublesome for us to explain and convince patient in this type of situation. We take utmost care of any of our patient in any emergency situation, but we never know. Accident may happen at any time, and once accident happens, it becomes a area for litigation. And our job is, we have to save mother, we have to save baby, and at the same time we have to save our own cap. This is our obstetric practice nowadays. Let us say this is real happen case in city of Ahmedabad only. Regular antenatal checkup, sonography every time, told everything is fine except mild polyhydramnios. At 34 weeks of pregnancy, during routine antenatal checkup, it was found a case to be intrauterine fetal death. So cesarean section was advised, preoperative investigations were done, and blood sugar was 432, which was never advised, never done in this particular case. And this type of blunder cannot be excused in court of law. Case was filed, notice was served, compensation demanded 1 crore. So in this type of situation, whenever there are important investigation, we have to advise, and if at all we miss, then it becomes a potential area as far as litigation is concerned. Let us see one more area, one more case. This is also real happen case in state of Gujarat only. It was unbooked patient, primary 34 weeks of pregnancy with PIH. As such, this patient was seen by another gynecologist in another town. But in Gujarat, it is customary tradition to get delivered in primary at maternal place. So she had been to her maternal place. So with this gynecologist, it was very first visit of this patient. Otherwise, she was taken care by another gynecologist in another town. So with this gynecologist, it was 34 weeks of pregnancy and PIH. So he advised all necessary investigation and treatment. But unlucky that patient and doctor too, very next day, she developed abruptio and intrauterine fetal death. Cesarean section was advised, relative opted option to go for second opinion, went to surgeon in nearby town, cesarean section was done, and again unlucky patient, she went into atonic PPH, and in spite of all efforts on part of treating surgeon, hysterectomy was done. So can you imagine the situation? Primary patient, intrauterine fetal death, and hysterectomy. Notice was served. Allegation to first gynecologist was not properly managed to prevent abruptio and IUFD. I was defending both of them, this gynecologist and surgeon, and ultimately we won this case. But in this case, this was the allegation on gynecology. So my argument was it was very first visit with that very gynecologist, and he had advised all necessary investigation which any prudent gynecologist would have advised. And he had advised all the necessary treatment also. It was unlucky on part of patient that very next day she developed abruptio, but there was no negligence or carelessness on part of gynecologist, and it was considered in court of law. So gynecologist was out of problem. And allegation to surgeon was not tried to prevent PPH, and atonic PPH was not managed properly. So in this case, he had, when this atonic PPH happened, he had tried all the measures to control bleeding: oxytocin, ergometrin, prostaglandin, and stepwise devascularization, compressive suture. He had transfused 2 units of PCV also. But in spite of all these efforts, bleeding was not getting controlled, and ultimately there was only way to save life of patient to go for hysterectomy, and he went with hysterectomy. So I could convince court that we have tried our level best to save uterus, but there was no measures we left behind to control PPH, but PPH was not getting control, and to save life of patient, it was the only option. So I concluded my argument that we have not removed uterus, but we have sacrificed uterus to save life of patient. And court was convinced, and case was decided in favor of both gynecologist and this surgeon. But in this type of situation, these are the area when IUFD occurs and ultimately stillbirth. In this case, we have to face litigation, because many times what happens, you said everything was all right just 10 days back, and but how, doctor, this happened? And it is very difficult for any gynecology, because it has great physical, emotional, psychological, and social trauma for parents and family in case of stillbirth. So in this type of situation, naturally we have to confirm the diagnosis. So I will not go into detail because previous 2 speakers has touched the subject. But in 50% of stillbirth are preceded by decreased fetal movement, and it is warning. When patient complains about decreased fetal movement, and if we do not advise properly, it becomes an area for litigation. So we should be very careful when there is a complaint on part of patient about decreased fetal movement. Because in one of the cases it happened, it was Sunday evening, and there was phone call from patient, and patient complained that it is decreased fetal movement. And doctor said, tomorrow morning you see me in my OPD. When patient came tomorrow, next day morning, it was IUFD. So in this type of situation, you cannot be pardoned. Sometimes fetal movement perceived even after IUD, and fetal movements can correlation at false positive rate up to 30%. Auscultation may be inaccurate, and with inaudible fetal heart sound, baby may be viable. So gold standard is ultrasound, and we can have assessment about placenta, its location, retroplacental bleed, and as far as fetal part is concerned, presentation, approximate weight, Spalding sign if it is old IUD, then eye drops, and gross anomalies. So we have to confirm diagnosis with sonography in this type of situation. So clinical evaluation, naturally we have to very quickly do exclude immediate severe maternal morbidity. So if patient is having severe preeclampsia or uncontrolled diabetes or so, we have to manage that condition very promptly and efficiently. So exclude immediate severe maternal morbidity, acute abdominal pain, rule out abruption. If patient is bleeding vaginally, then we have to take care of that also. If labor symptoms, pre-prom, obstetric emergency like eclampsia, maternal collapse. So in this situation, we have to manage patient accordingly, because it is taken into consideration whenever we are facing litigation in this type of situation, whether we manage this situation way in which any prudent gynecologist would have managed. So we have to manage that part only. And if we fail to detect or to manage in time, it is considered carelessness and negligence on part of treating doctor. So we should be very careful in this type of situation. evaluate probable cause of IUFD, and communication is very much important. As far as probable cause is concerned, Aparna has nicely mentioned about all the etiology and probable causes for IUFD. So as far as communication is concerned, to the patient, to the next of kin, and relevant authority because in few of the institution it is routine to report to head of the unit, head of the department, and medical superintendent, and ultimately in record department. So we have to follow that protocol. But as far as communication with patient and relative is concerned, it is a very difficult situation for any gynecologist. The most terrible thing that can happen to an obstetrician to declare bad news. And where do we go from here? Because it is very many a times it is very difficult to face patient and relative in this type of situation. And here comes the role of RUST team. So what is RUST team? In each society, there should be RUST team. So member of RUST team can be helpful in this type of situation. Sorry. to the doctor facing the situation. And as far as RUST team is concerned, it could be helpful in surgical assistance whenever you are dealing with a case of PPH or any other emergency. At the time of declaring bad news, at the time of incidents of assault or mob violence, or in case of medico-legal problems. Sorry. So whenever RUST team is available, it is always better to call RUST team at the time of declaring bad news. And in this situation, main chair belongs to the owner or head of the team who has treated that very patient. And communication is his job only. As a member of RUST team, we are there to help him, but role of RUST team is only facilitator. And do not take it as an opportunity to settle score by giving subtle hints to relative that there was negligence. Many times it happens in RUST team, say for example, any senior person is there, and if any known person in relative, then he will say, do you remember that very case you had been to me with that very patient, and with our sincere effort, we could save that very patient. So this type of comments will be very much difficult for person who is facing a patient to declare about this bad news. As far as communication with relative is concerned, हम आपके बच्चे को बचा नहीं सके. It seems good in the film, but in our day-to-day practice, it is not that simple to mention like this. So inform condition from time to time. If we are dealing with a case like GDM, severe preeclampsia, severe IUGR, abruptio. So in this type of situation, we know sudden IUFD is known. And if we have informed all this, it becomes little easier for us to face whenever we have to declare IUFD in this type of situation. It should be by senior most person, just I mentioned prior also, not by junior. Be polite and sympathetic at the time of declaring, but at the same time, you should be assertive. Be prepared for knee-jerk hostile reaction because we never know what could be the reaction on part of relative of the patient. Be prepared for mob frenzy. Do not lose patience. Do not blame each other. When more than one person is involved in treatment, never blame each other in presence of a relative of the patient, because it becomes very difficult in this type of situation if you blame each other to face the situation. Use private room, mentioned by previous speaker also. Arrange interpreter if necessary. But in this situation, avoid using family members as an interpreter, because we never know how family member has interpreted to the patient. Discuss care and decision with both parents and or a support person, and document plan of further care. So what is your plan to go in this particular case further, to deliver or to wait? So whichever way you are going to, but it should be well documented and it should be well explained to the relative or patient. Nurse, registrar, other members of your team should be available to patient's relative for their conversation or about information and outcome, etc. But before that, we should have word with our staff, nurse, registrar, or any other member, actually what was the problem, what happened, and what we have done, and now what we have to tell to the relative of the patient. Management plan, how to deliver this patient or to wait, and certain investigation. It was well covered by Upma Saxena madam, so I do not want to go into detail, but clearly document in chart, in consultation with parents, how you are going to deal with this patient further. Care of stillborn baby is also well covered by previous speaker, but get verbal consent for initial examination is consent, because consent of patient and relative is very much important. Offer parents opportunity to dress and hold her baby if they are comfortable to do this in this type of situation. Assist parents in taking photographs of baby, and it is also mentioned by previous speaker. Take and offer mementos, hand or footprints, lack of hair, name band, cord clamps, memory box, photographs, whole body X-ray infantogram, and ultrasound scan. A very personal decision for parents as far as fetal biopsy or autopsy is concerned. Of course, we have to explain them what is the importance of fetal autopsy for future pregnancy planning also, and for other patient also in this type of situation. But consent are very much important. And as far as fetal autopsy is concerned, it helps diagnose to cause of death or add information in 22 to 76% of the cases, may change final diagnosis or affect genetic counseling, and in clinically unexplained stillbirth, the relevant condition at death classification is recommended. If parents decline autopsy, then we can explain about importance of autopsy. Even then, if they are not ready, then we can we can request them for full body examination of baby by neonatologist, by pediatrician, by pathologist. But for that also, we have to obtain consent for external examination and for clinical photographs also. Do not forget, the bereaved parents need lots of support. Each person is different and will go through their own grief as it suits their personality. And you cannot do anything to make it better, but you can be present to be there with them in that very situation. But in all this situation, documentation or record keeping is very much important, because these are the potential conditions as far as litigation are concerned, and you are saved in court of law only by documentation and proper record keeping, what you have done for that very patient, and what was the reason for this IUFD or stillbirth, and you can explain in court of law that you have taken utmost care of that very patient in that given situation. You have to document all these OPD papers indoor, whether it is your book patient or unbook and emergency patient. As far as documentation checklist is concerned, as far as maternal part is concerned, physical examination, comorbidities like GDM or preeclampsia or so, emotional status, scan findings, presentation, placental position, gross anomaly, Leica amount, placental site, whether it was fresh IUD or it was old one, it is also to be mentioned in our record. As far as baby part is concerned, gender, birth weight, gestational age, date and time of birth, and if it is twins, then label twin 1, twin 2 with placenta, cord, etc., and photo documentation. So we should be updated with our documentation. Labor ward register, stillbirth register, stillbirth certificate, notification, ensure discharge summary provided is accurate. We have to give all the instruction in discharge card about diet and medicine to be taken, follow-up visits. If any reference is advised, then it is also to be mentioned in discharge card. It is very important part as far as discharge card is concerned. Preventing future recurrence. This is a very important part, and we have to counsel for that also. So preventing recurrence is very much important, because if at all that same patient comes to you, and if second time it happens, then it becomes very difficult for us to face the situation and to explain or convince the patient. So preventing recurrence is very much important, because 592,000 stillbirths per year in India, 50% are intrapartum, and 43% are growth restricted fetus concern is concerned. So cannot we prevent all this? Of course, yes. So with meticulous planning and management of a case during antenatal period and during intrapartum part, we can reduce this burden of IUFD also. Strengthen antenatal clinical screening as far as future pregnancy part is concerned. Risk stratification, we have to identify the risk involved in that very pregnancy, and we have to counsel patient and relative accordingly for the same. Antenatal pickup is key to management, particularly in remote area. We have to convince them for institutional delivery, and if there is any risk factor, then these patients are to be transferred or referred to the higher center well in time. Clear referral algorithm, it is given by government also, and we have to transfer patient well in time. Protocol-based management is of course required. It shows your concern that you have taken utmost care of that very patient in given situation. Skill training and equipment for management, moral support to the couple, and avoidable factors in perinatal death. Patient delayed in admission. Many a time patient reaches hospital late, so it should be taken care in future pregnancy. Delayed in care on admission to birth facility. Even after admission, many a time there is a delayed in starting of the treatment, delayed operative delivery, unavailability of health workers, inadequate intrapartum monitoring, misuse of oxytocin. So these are the area which can be taken care of, not to have IUFD or stillbirth in future, and we can control all this. Neonatal resuscitation part is also very much important, and it should be well back up as far as neonatal part is concerned. So every newborn action plan targets neonatal still rate, it should be less than 12 by 2030. It is given by WHO and Government of India. So you were born silent, perfect and beautiful, still loved, still missed, still remembered every day, still born, but still born. But in this situation, question to face whenever you are facing stillbirth or IUFD, and very important question will be asked, was it preventable? And usually you cannot say no, because everything is preventable as far as medical part is concerned. So if it is yes, then what did you do to prevent it? So it is very important part that whichever measures we have taken to prevent stillbirth, it is very much important. But in spite of all care and caution, you couldn't prevent in few of the cases. Then why you couldn't prevent it will be one more question you will have to face in court of law. And did you diagnose well in time? Any complications or IUFD? And very important question, did you manage way in which any prudent doctor would have managed that very situation? So if you can answer all those questions, then you could be out of problem as far as litigation part is concerned. Because every IUFD cases are potential threat. So what to do and how to prevent all this? Practice foreseeability, anticipation, good communication and valid consent, and proper documentation, and you will be simply sail through. As far as foreseeability and anticipation is concerned, court and law expect from us to anticipate certain complication or certain condition where we may end up into IUFD or stillbirth, and we have to counsel a patient accordingly. Say, for example, if it is a case of GDM, severe preeclampsia, we know sudden IUFD is known in GDM or preeclampsia or in severe IUHGR. So we have to explain all this to the patient in this type of situation. So proper counseling in this type of situation is very much important, and we have to counsel patient with all its probable outcome, and no rosy picture about result, no tall claim about result, because once you claim to be master, you are supposed to be master in eye of law. And in our obstetric practice, we consider result like Aishwarya Rai, but it may turn like this at any time. So no rosy picture, no tall claim. And records are always at our rescue. So keep them up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics. And it should be easily acceptable whenever offered in the court. So there is always a way. So to conclude with carry home messages, Always confirm IUFD by USG. Breaking news of IUFD should be done very carefully and compensatory. It can help us avoid a lot of medical legal issues that can develop with these cases. Investigations are done primarily to find out the cause of death. In spite of all test causes is not found in 25 to 60% of the cases. History taking is most important part in evaluating a case of IUFD. Vaginal delivery is preferred route unless it is contraindicated. Use prostaglandin with caution in scarred uterus with IUFD. Cytogenetic evaluation will be helpful wherever no apparent cause is found. A postmortem may be advised. In certain cases of fetal autopsy can provide an insight to the cause. And be very vigilant in next pregnancy. Continuous support and reassurance is very much required in next pregnancy. And in any case, never take pregnancy beyond 39 weeks in women with history of IUFD in prior pregnancy. Pregnancy and labor work protocol, we have to strictly follow all the checklist and pregnancy profile. If you have managed any patient as per standard guideline by ICOG or FOXY or RCOG, it shows our concern that we have taken utmost care of patient in that given situation. Proper counseling and consent is very much important. Naturally, documentation is always at our rescue. Multi-speciality approach in this type of situation. Involve your professional colleague in managing the patient. No compromise on statutory requirements, and professional indemnity is very much must in era of CPA. So be vigilant in your practice as far as this type of situations are concerned. Otherwise, be ready to face this type of situation in obstetric practice. Comply with the provisions of law. Formation of local level medical legal cell or surgical rush team is very much important, because anybody can have help in given situation. Take medical legal advice from point one if at all you are facing this type of situation, because this gentleman have so many staircases, but he doesn't know how to use them. It doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So God bless you. Have a litigation-free medical practice, because in spite of all these professional and occupational hazards, our journey to serve human and mankind is always on and on. So if you want to sleep like this, take tender care of your patient, comply with the protocols and checklist, pray Almighty God before going to sleep, and keep my visiting card below your pillow. So with regards, salute to all. And again, it is my promise, wherever you are, I will be there. Promise to reach unreached in any given odd medical legal situation. And again, seeking your blessings for post of President Foxy election year 2026. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much.
Thank you so much, sir. It was an excellent, mesmerizing talk.
Correct.
Too good.
Absolutely, sir. Thank you so much, sir. The talk has been really very insightful, so impactful, and no, who else can be better than you for a medical legal talk? So
Thank
we are
you.
really enlightened, I would say, very enlightened, and really proper documentation, proper recording definitely is the need of the hour. And definitely, whenever this IUFD is a real devastating thing for a couple. So whenever we have to break a news, you have very rightly said that it should be, we have to have a very polite attitude, very sympathetic attitude, and break the news in a private room, have a proper communication with the patient. And I think that is very reconciling and very supportive to the parents. Otherwise, and definitely we have to be assertive also. It's not that, you very rightly said that a senior person should be breaking the news, and definitely the supportive staff also should, they have to know what is really to be said.
Yes.
I think really truly very thankful to the talk, and all the best, sir, for your candidature. We wish you
Thank
all
you.
the success, really seeing you as a Foxy president
Thank you.
2026.
Thank you.
so much.
Thank you, Dr. Preeti. Dr. Pancham, can we
Yeah.
have your comments, please?
It was an extremely informative and engrossing session, sir. Starting from the Statue of Unity till Aishwarya Rai and the chimpanzee, we really enjoyed.
Thank you. Thank you.
And in this era of Google, and I think now ChatGPT and Google Gemini and whatnot on internet, everyone is so much aware and fully overloaded with the information. So we have to be really careful, and a beautiful presentation. One thing just I would like to reinforce to our delegates who were there. Sometimes unknowingly or knowingly, जैसे patient आए, अच्छा इन्होंने ये कर दिया. मतलब we have to be very careful of what we speak unknowingly to the patient
Yes.
relatives also. So that is something which is very important, and the empathy part is too important. And really enjoyed the talks. Thank you so much, sir, and thank you for having me here.
Thank you.
Thank you, ma'am.
Dr. Renu ma'am, please. मैम आपकी आवाज म्यूटेड है शायद. मैम, we can't hear you.
मैम सर की स्लाइड का वो बहुत टचिंग पार्ट था. स्टिल बॉर्न बट स्टिल बॉर्न. Sir,
Yes.
it really touched my heart. That slide was wonderful. Congratulations, sir.
you.
Wonderful as ever.
Start से लेके finish तक everyone heard your talk.
I think
यहाँ से
best talk on medical legal aspect of stillbirth.
Yes.
Thank you, ma'am.
आपकी आवाज आ नहीं रही.
Muted, I think. Mute दिख भी नहीं रहा है. Can't see mute also.
mute तो दिख नहीं रहा है.
हाँ, अब दिखा muted. अब हाँ, she's unmuted but
तब
she's
तक
not.
जया को बोलने दो. तब तक जया को बोलने दो.
Just no. Then we can conclude this session and switch over to panel.
डॉक्टर जया तो मैम, डॉक्टर अनीता, डॉक्टर जया तो मॉडरेटर नेक्स्ट.
हाँ, panel
moderating. She's
Well,
moderating.
she was also looking. I thought she was trying to say something.
She was waiting for her panel.
Yes.
So I'm all there to appreciate sir's talk. I'm always mesmerized by what he says, and this was yet another time. Excellent, sir.
Thank you.
Yes.
So, I request Dr. Satabji to please take over and get the panel discussion started.
Thank you, ma'am. Thank you so much. Thank you, MC sir, once again for that very eye-opening session, I would say. Your sessions are always giving us so many revelations. Thank you. We will move on with our next session. We have a very important and pertinent panel discussion. It's on prevention of stillbirth. It will be moderated by Dr. Jaya Chawla, ma'am. Ma'am has been the Joint Secretary of the Society of Fetal Medicine Delhi chapter, also the Professor and Head of Department and ABVIMS and Dr. RML Hospital. Welcome, ma'am. Our experts for the sessions are Dr. Neelam Agarwal, ma'am, as well, and Dr. Professor Tamkin Khan, ma'am. Dr. Neelam, ma'am, is the President of the Stillbirth Society of India, as well as Professor at PGI-MER at Chandigarh and Founder President of the Stillbirth Society of ma'am. Glad to have you here, ma'am. Welcome. Our next expert is Dr. Professor Tamkin Khan, ma'am. Ma'am is the Founder Secretary of the Stillbirth Society of India and is a professor at JNMC and AMU at Aligarh with over 30 years of teaching experience. Welcome, ma'am. We have 7 very noted panelists with us. Our first panelist is Dr. Manisha Kumar, ma'am. Ma'am is the Director and Professor and the Lead Consultant in Fetal Medicine at LHMC in New Delhi. Welcome, ma'am. Next, we have Dr. Ratna Vishwas, ma'am. Ma'am is the Director, Professor and Head of Department in OBGY at Lady Harding Medical College and Srimati Sucheta Kriplani Hospital. Welcome, ma'am. She has been the Honorary Secretary of AOGD in 2025-26. Next, we have with us Dr. Rachna Agarwal, ma'am. Ma'am is the Director, Professor and Head of Department at UCMS and GTBH at Delhi. Also has been the co-author of various books. Welcome, ma'am. Next, we have with us Dr. Veronica Arora, ma'am. Dr. Veronica has over 70 papers and books to her credit. She is the Secretary of the Delhi chapter of ANBAI, also the Managing Committee member of National Ispat Society. Welcome, ma'am. Next, we have with us Dr. Sangeeta Gupta, ma'am. Ma'am is the Director, Professor at Maulana Azad Medical College, New Delhi. She established the Fetal Medicine Clinic at MAMC and LNH in New Delhi and has vast experience in invasive procedures and screening of aneuploidies. Welcome, ma'am. Next, we have with us Dr. Sumitra Bachani, ma'am. Ma'am is the Professor and Faculty of Fetal Medicine and Genetic Clinic at Vardhaman Mahavir Medical College and Safdarjung Hospital. Also is a fellow of the maternal fetal medicine from AIIMS Delhi. Welcome, ma'am. Last but not the least, we have Dr. Sangeeta Gupta, ma'am, with us. Ma'am is the professor at ESIC Medical College and Hospital, Noida. She has been the ex-HOD at ESI, PGI, MSR at Basai Darpur, Delhi, and founder secretary of DGF, and presently the vice president of DGF. Welcome, ma'am. Over to you, Jaya, ma'am. Looking forward to an excellent panel discussion.
Thank you so very much. Permission to share my screen, please.
Yes.
डॉक्टर जया, आपके पास में एक्चुअली सब 9 के 9 सब एक्सपर्ट्स हैं. सब आपने धुरंधर दे आर ऑल सो सीनियर.
मैडम, मेरा तो आदत ही ये है कि मैं सीखने के लिए पैनलिस्ट चुनती हूँ.
यस यस,
इन सबसे मैंने बहुत सीखा है, आज फिर से सीखूंगी.
Yes, yes, you have got all the senior most people there on the panel. They are all
Actually, ma'am, actually all of them professors and HODs, really senior people. And looking forward to it, ma'am.
You shall soon see that they will.
what a panel, and it's right. She's correct. What a panel. Hats off to Dr. Jaya, ma'am.
I would start off by saying thank you, a big thank you to MC Patel, sir, for entrusting me with this responsibility. Thank you, Dr. Monica Amarwant and Dr. Deepika Logani. It's excellent to connect with you yet again. I welcome to the panel our experts, Dr. Neelam Agrawal, madam, and Dr. Amkeen Khan, madam. They are the light at the end of the tunnel insofar as stillbirth is concerned. And I thank each one of my esteemed panelists for agreeing to be a part of this panel under a lesser mortal like me. Thank you so very much, each one of you.
Dr. Jaya, am I audible?
Very much, Rachna ma'am.
Yes, ma'am.
Okay.
So we begin with saying that India is indeed shining. But sometimes we are topping the wrong charts as well, and we all know that. So is there really a concern for the entire world? Yes. Like my previous speakers have already said, every 16 seconds, a mother loses a baby, a family loses hope, and an obstetrician takes a setback. So yes, it is indeed a concern. So without much ado, I take my first case, and that is a 32-year-old lady, primary gravida, 30 weeks gestation, presents with decreased fetal movement since 1 day. There's no other complaint otherwise. She has a GDM on oral hypoglycemics, hypothyroid, and has moderate anemia. She's conceived on ovulation induction just 11 months after her marriage. She's a known case of PCOD on metformin 250 milligrams BD since her preconception period, and her family history is not significant. So in the first trimester, she undergoes a 75-gram OGTT and has a fasting value of 110, a first hour value of 150, and a second hour value of 138. So the clinician that she goes to increases the dose of 250 milligram BD to TDS. Her thyroid function reveals TSH of 5.2, and therefore she's put on L-Troxin. Otherwise, her first trimester morphology scan and combined first trimester screen are all low risk. So my first question is to Dr. Ratna Biswas, ma'am, please. Ma'am, who should be screened for GDM in pregnancy, and how should we do it?
So GDM, basically Asian population in India, we are high risk population. So every pregnant woman needs to be screened. And nowadays it is recommended that every woman should be screened in the first visit itself. So first trimester. And how to screen? That was the second question, I think.
Yes.
So how to screen? There is a little this thing choice there. You know, the Indian guidelines they are favoring DIPSI. Like we all are doing DIPSI. I'm getting a call. Just a minute. So DIPSI is the one which we are doing, but we there is also other tests which can be done. So IADPSG 75 grams OGTT is also being practiced by in many institutes, many places. So it depends on what guidelines you are following. So as of we are following the DIPSI, but in high risk pregnancies where we
Somebody's
think
voice is disturbing in between. Can that person be muted? Yeah.
So in high risk pregnancies, maybe where we think that we are missing out the fasting hyperglycemia, there we can go for the 75 grams OGTT. Personally, I do a DIPSI for all women, but in high risk pregnancies, I prefer to do a 75 grams OGTT.
Very well said, ma'am. In fact, Dr. Aparna also raised a similar question in her talk saying, are we missing out on fasting hyperglycemia by practicing universal DIPSI? And I would like to share here that Dr. Amkeen Khan ma'am is here with us, that the Stillbirth Society of India guidelines do suggest that perform screening for gestational diabetes mellitus at booking visit using a 75-gram OGTT, repeat in the second trimester, and DIPSI may be used for screening if fasting OGTT is not possible. So we do really have parallel opinions on how to screen. And Ma'am Ratna, you've pointed it out very, very beautifully. We may move on to the next question, please. How will you like to manage her blood sugars in trimester 1? And this is for Ma'am Rachna, please.
Yeah. In first trimester, she has we'll put her on medical nutrition therapy along with exercise and give her at least 2 weeks period to normalize, because like in this case, putting her on oral hypoglycemics straight away would not be my point of opinion, because first of all, oral hypoglycemics are not as such recommended, and we should try with medical nutrition therapy first along with exercise. And there's a full panel like 40% carbohydrate, 40% fats, 20% protein, take for 3 meals, 2 snacks, low glycemic index food, and all the recommendations. Calculate the calories according to her activity, BMI, then give her exercise at least 30 to 60 minutes per day, at least 5 times a week. Like this all has to be explained, isometric exercises, aerobic exercises, and it really plays a role in controlling GDM's cases. And they are controlled, and her blood sugars can be monitored by doing fasting and postprandial. That would be my recommendation. HbA1c, I think you're coming on later on with that question, which I'll point out. But initially, HbA1c for a preconception period, HbA1c has a role. But as such, monitoring after starting diet and this exercise, it was fasting blood glucose and postprandial, where we set a limit. Like the limit is +2 standard deviation. The highest limit, which is fasting, should be within 95. Postprandial 1 hour preferably, because that is the 1 hour is the time indicating insulin spike, and that insulin spike causes hyperinsulinemia which in the fetus, and which is the cause of later stillbirth. So we should prevent fetal hyperinsulinemia. So the 1 hour 140, which has been decided like on based on various studies as the upper limit, that should be considered. And if somebody wants 2 hour, it is 120. So that would be after 2 weeks of therapy. If still not controlled, then we may consider adding insulin. For me, I consider, as per the recommendation, insulin as the first line therapy. If the blood sugar levels lie beyond 30%, if the 30% of the blood sugars are high, like after doing fasting, postprandial, if we plan to do, if still not controlled, we may go for a 7-point profile. That 7-point profile would be pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner. So we may next step would be to do a 7-point profile. And if the 30% of the values of those sugars if deranged, or if we are seeing signs of hyperinsulinemia in the fetus in the form of fetus developing macrosomia, abdominal circumference more than 75%, or effective fetal weight more than 90%, or if the blood sugars are going beyond the upper limit, then we may consider insulin therapy and so on. And then we may modify the insulin or consider adding oral hypoglycemics.
Thank you, ma'am. Ma'am, considering this to be the first trimester, these signs of hyperinsulinemia will take some time to actually unfold.
I bypassed first
we will
trimester.
have to clue in a bit to what would happen in these initial periods of time. So yes, very well pointed out. So we move on to the next. And what are the indications of initiating therapy early? Ma'am Ratna, could you please take us through this one?
So you mean
In
when
the
to
first
start
trimester.
insulin early rather
Yeah,
than
like
wait for
Madhu
the
said.
effect of MNT? That is what
Precisely,
you.
ma'am.
Yeah.
Precisely, ma'am.
So
Like
there
Ma'am
are
Ratna
certain
described the
conditions.
usual thing.
There are certain times where we do not wait for MNT, like when the sugars are very, very high. Suppose you get a fasting of more than 126 or a random of more than 200, where your MNT is not going to suffice. In fact, you might go into DKA or something, waiting for the MNT to work. So in those conditions, we need to start insulin right away. In addition to MNT, we need to start insulin.
Other than
Right.
that, if she is on, the patient has been diagnosed at a stage where she has already developed complication of diabetes, like she has developed polyhydramnios, or she has developed macrosomia, she has developed this thing. Or fetal growth restriction due to diabetes. Those are also the conditions where the sugars are not controlled. That is why the baby is not developing well. So there also we need to start insulin. And in times where suppose we are giving her steroids, where the sugars suddenly spike, there you need to give her a backup insulin during that period of time.
Yeah.
And there are situations where sometimes like if it is diagnosed very early also, if the like hyperglycemia is diagnosed before 20 weeks, that means she could be an over diabetes, so these
Yes.
are the times you might have to start insulin earlier without waiting for the effect of the MNT.
Yeah, precisely. She's a PCO in our case, and she was already insulin resistant, where she had been put on metformin. So, like, this is one of the clues that we might place in the history and say that she could be potentially one of the candidates who was harboring diabetes mellitus prior to pregnancy, maybe, and her first trimester values itself have come out to be abnormal. So maybe
Yes.
this is somewhere where we can, lower our
Yes,
threshold
definitely.
and start off a little early. Perfect. So the next is the second trimester history, and the mid-trimester anomaly scan only suggested an echogenic intracardiac focus. And the blood sugar charting that had been performed said fasting was between 95 to 125. So this is a little beyond the control that has been suggested by Ma'am Rachna. And the PP was between 92 and 128, which can probably be accommodated by most of us. HbA1c value at 18 weeks, 1%, otherwise an uneventful pregnancy. So, Ma'am Rachna, how would you monitor this blood sugar? You've already taken this one, though. We
Yeah.
were yet to discuss HbA1c part of it
Yeah,
as a
yeah.
test for surveillance. So we can continue with that.
So, HbA1c is not a very good test for pregnancy. First of all, the HbA1c's cutoffs have been decided for an adult population. They have not been worked out for a pregnant population. And in pregnancy, we know there are a lot of physiological changes. There is increase in red blood cell mass, and there is RBC turnover. So the glycosylated hemoglobin, which is very much dependent on the RBC population, so the HbA1c's are altered, and there are not defined cutoff for the population. In addition, anemia of pregnancy also alters the HbA1c value. It is falsely increased. So the interpretation of HbA1c as per the recommendation, it is not a preferred choice for monitoring. It is the average glucose value, which is actually nowadays we have continuous monitoring devices also, which can be installed on the arm of the patient, and they give the average blood glucose value, and that are more of significance. And even in adult non-pregnant patients, nowadays they are shifting from HbA1c to mean blood glucose level or the average glucose, and HbA1c is more of use at the time of conception to know the
Yeah.
last 3 months whether there's a chance of congenital anomaly and all. If it is more than 6.5, it is said that 25% chance of congenital anomaly. So during pregnancy, it is not the choice. During pregnancy, blood sugar, 7-point value, or fasting or postprandial value, according to the case, we can monitor four levels or 7-point, according to the tight control which is warranted and according to the blood sugar status.
Yeah, this patient was a moderate anemia, and therefore that could have contributed to a lower HbA1c actually, which was 5.9%. But that could have been attributable in part to the moderate anemia that she was carrying, in addition to her other conditions. So she came at 30 weeks saying decreased fetal movement since 1 day. She was offered, BP was checked to be fine, NST was reassuring, biophysical was excellent. The AFI was 12 centimeters, the umbilical artery PI was not raised. The next day also the same surveillance continued and the similar findings were there. 30 weeks and 2 days, so precisely third day of her admission, her FHS was not localized. An ultrasound suggested it to be an intrauterine fetal demise. She was induced and a female baby, 930 grams, was born. By the intergrowth charts, this would be around 1 centile. And the baby was not macerated. The placenta weighed 293 grams, cord was 3 vessel. The infantogram is attached herewith and did not show too many concerns. The placental histopathology suggested syncytial knots, villus edema, and distal villus malperfusion. When the autopsy The baby had depressed nasal bridge, low set ears, scoliosis, and a duplicate posture on the right side. Now, Ma'am Sangeeta Gupta, please. Ma'am, what do you think is the cause of fetal loss in this particular case?
So, Jaya, in this case, I think there were multiple factors which could have caused the fetal loss. And I think the most obvious cause was the syndromic baby. Despite having diabetes, I think it wasn't that badly controlled. Like attributing the primary cause of fetal death to diabetes, I would not do that. It is probably the syndromic baby which had delivered. And I would definitely like to take an opinion of a geneticist. Number two, there were contributory causes. The first one being, of course, diabetes. And as far as FGR is concerned, I think it is not a matter of, there is some suggestion in the placental biopsy, yes, that there is some degree of placental insufficiency. But a syndromic baby itself, FGR is a part of the syndromic fetuses, chromosomally abnormal fetuses. So that debate will only be settled once we do a autopsy and we do the genetic testing. And I think that's my primary analysis as far as this case. The only thing which we do not have a background of is that what was the pre-pregnancy status of this woman as far as her diabetes is concerned.
हमको पांडे जी बोला हम जजमान पेट्रोल पंप मुझे बोले कि नहीं लक्ष्मी मार्केट जाना है
He had
भगवान
testing, the results of which were not available to
हमको
us.
रंजीत बोल रहे हैं कि मैडम आपके घर के सामने गाड़ी आ गया है तो मेरे को कहीं गाड़ी दिखी नहीं रहा
in the background.
रंजीत को हम बोले हम मैडम जहाँ बोले थे वहाँ गाड़ी खड़ा है
हाँ अच्छा क्योंकि रंजीत मेरे को बोला कि मैडम गाड़ी आपके घर के सामने है मैंने कहा यूजुअली जब गाड़ी आता है
आपको हम नहीं लगा
Dr. Nivedita, since we have a question. Yeah, Sangeeta ma'am, please. So you were talking about some genetic causes, ma'am, that could probably have been attributable to this particular disorder. So, ma'am, in that event, we take Dr. Veronica's opinion on what tests could have been performed as a geneticist, what she would like to offer.
Thank you, ma'am, for the question. Good evening, everyone. So here we offer the couple genetic testing. Now, genetics testing in the presence of multiple malformations as a dictum. The first test we do is to rule out chromosomal disorders. As we can see in this chart, there are three main tests, but for getting the maximum diagnostic yield, chromosomal microarray is our test of choice. When we have the first occurrence, we do not have any family history, we have stillbirth with multiple malformations, the first test we'd like to do is a chromosomal microarray, of course with the detailed phenotyping in the form of fetal autopsy. And if the couple also wants further testing, then we can discuss the test for monogenic disorders that includes Sanger sequencing, exome sequencing, and which increases the yield of testing around 3 to 4% beyond the 15% for chromosomal microarray.
Right. So in this case, the microarray was offered and it turned out to be NAD. The genetic part was, Dr. Veronica, do we go beyond the microarray in case it turns out to be normal?
So for the first occurrence, we generally do not go and mandate the microarray, but it is important to offer to tell them that a normal microarray does not rule out all genetic causes, and they can go for an NGS-based monogenic test, but it is only going to marginally increase the yield of testing.
Fair. Thank you for that one. So, Ma'am Sangeeta, I come back to you to say that, like, if a genetic cause has been ruled out, under such situations, what would you now say that is the cause of fetal loss in this particular case? Sangeeta ma'am, please. Sangeeta ma'am, are you there?
Dr. Sangeeta, please unmute.
I've unmuted myself.
Yeah, ma'am.
So, see, even if a genetic background is ruled out, that definitely we can see it's a syndromic baby. So the likelihood is that the baby is syndromic, and the recurrence risk for this in the next pregnancy is going to be much less. One. Second, yes, this patient would need a better control of diabetes. So we need to make sure that she comes back to us in the preconceptional period. And before she conceives, she's got a good glycemic control, her HbA1c has been brought in the normal range, and we can supplement this patient with higher doses of folic acid to prevent further. So definitely one, I think what needs to be done is that her diabetes is controlled. And as soon as she conceives in this pregnancy, because there was some evidence of placental insufficiency also, so she becomes a good candidate for screening in the first trimester by besides your aneuploidy screening, your diabetes and rest at the other workup. She should also be offered PLGF, uterine artery Doppler. There's one thing which I would like to talk here is that from the beginning of the session, we have been talking about prevention of stillbirth. What I want to give a message here is that not only just for prevention of stillbirth, but before aneuploidy screening, we should very actively advocate screening for preeclampsia, universal screening for preeclampsia in the first trimester. So because she has had a stillbirth, here a screening of FGR with the same algorithm will also be worthwhile. And we can make a shared decision with the patient if we can put her on aspirin in the next pregnancy after doing a screening. So I think that's what I have to say.
Very valuable, ma'am. The mother always scores above the baby, and therefore preeclampsia screening would always score above any fetal anomaly that we are trying to look at. And I would thank the society and the Stillbirth Society and Ma'am Tamkeen Khan, from whom I've borrowed the IIC material for this particular slide, because I wanted to convey through this slide that there's a lot that exists and which we can disseminate further in order to prevent stillbirths. So coming to our next question, ma'am, what causes a sudden IUFT in gestational diabetes mellitus? Ma'am Manisha, please.
Yeah, so thank you very much for including me in this panel. So basically, in GDM, we have seen that hyperglycemia leads to fetal hyperinsulinemia, and that can cause myocardial problems. Plus, there is, of course, there is a placental thing which is in the background. So there is maternal vascular malfusion, which has been seen and which have been categorized very well in Amsterdam classification, and it has been further taken by Ernest et al. And they have said that there are actually by maternal vascular malperfusion, they actually mean that there is thrombus or there is some infarction in the placenta, which makes it insufficient. And they have mentioned certain characteristics which makes it, which is helping us to identify. So, so like I was discussing, there is a software also in which you can put the histopathological findings, and you can actually know, like if you are, doubtful whether it was FGR or it was infection or was it diabetes that is causing. So you can, at least tell the parents some cause, some definite thing that that was there in this pregnancy that has led to this. So you have very beautifully described the MVM, how does it causes chronic decidulitis, and there is, of course, infarction and thrombus. So these things are actually responsible for.
Manisha, would this imply that, there has been a traditional understanding that hyperglycemia will lead to a bigger baby? We often say that if there was a pre-existing diabetes of long standing, then only vasculopathy would ensue and cause FGR. So is this hypothesis and is this new knowledge coming to us to believe that even gestational diabetes due to terminal villus malperfusion can contribute to hypoxia and growth restriction in babies? Is that
Yeah, it has been found that it can cause both. Plus, there is another element, like if there's a gestational diabetes, the patient is more prone to hypertension, and hypertension can lead to FGR. So that is also there. But plus, there is insufficiency also, and like we know that the placenta becomes bigger, but placenta can be small and they can be retroplacental clot. These are the morphological things that we can see even in diabetes, especially in cases of stillbirth. So it has been seen that these are the gross features of maternal vascular malperfusion, and it has been seen in diabetes also. So not necessarily the placenta will always be bigger.
Fair enough. That was very
Jaya,
valuable.
can I add something here?
Absolutely.
Yes.
Absolutely, ma'am.
In
With pleasure.
fact, with the advent of very high use of metformin in diabetic women, what we have observed is that if the baby is small and you add metformin, it is going to add to the smallness. It contributes to the growth restriction component in a metformin causes growth restriction. So that becomes an added brunt, particularly in the kind of babies which Dr. Manisha was just talking about. So we should be careful in choosing which patients we can put on metformin.
I would just like to, ma'am, stretch this a little more and ask you again as to what would be your choice for a first trimester woman who has been identified with hyperglycemia in pregnancy. Would I like to offer metformin as a first choice?
See, I have one concern when I put these women on metformin, because metformin itself takes about 1 to 2 weeks to bring its effect. So for me, always in diabetes, insulin is the first choice. I only pick up metformin in my selected cases where I feel that compliance is an issue. But there is no doubt, I think now, that insulin is the drug of choice. Yes, metformin has been promoted because of the ease of use and ensuring compliance. And first trimester is a time when you cannot allow hyperglycemia to persist, because it's the time when organogenesis is taking place. So it's a very sensitive.
And Dr.
Nevertheless,
Sangeeta,
on the other hand, we have to be careful that putting her on insulin, we are not going to cause hypoglycemia.
And that has to be balanced.
Dr. Jaya,
Ma'am, Rashida
certain
wanted to say
cases
something. Yes, please.
where the patient was PCOS already on metformin and well controlled, that would be, Dr. Sangeeta, if you agree, that would be some of the cases where we can continue metformin.
Yeah, sure.
Yeah.
So that is what I said, that we should select the cases for metformin. Obese women is another set of women where you would like to maybe prefer metformin. But in first trimester, if a woman has with delayed sugars, my concern is that organogenesis is going on, and metformin, if started at that time, might take time to bring her to euglycemic state.
That was a very, very useful insight, ma'am, for your successors like us, that a careful selection is very important, and a thumb rule of mathematics does not apply to all women as a blanket idea. You have to look at the woman. For example, this one had acne. She had hirsutism. And she was very anxious that because of my insulin resistance, I will not be able to conceive. So at 11 months of pregnancy, she said, I want to resort to an infertility clinic and conceive through OI, because I think I am at risk of not being able to conceive easily. So all that put together helps us to, navigate our pharmacotherapeutics accordingly. It was very, very well put. Thank you so much. So Dr. Veronica, you've already contributed with this one, and thank you for that. So now, how should a patient presenting with decreased fetal movements be assessed? Ma'am Sangeeta Gupta, please. Ma'am. Sangeeta, ma'am?
I think, Jaya, you have to specify there are two doctors.
Ma'am, yes, Sangeeta, ma'am.
That's great. Yes. Yeah, always a confusion between Sangeeta Gupta, ESI, and Mamsi.
Good
So
evening,
thanks,
ma'am.
Jaya, for including me. And I think a patient, Jesse, from the beginning, we are listening from Dr. Aparna that we all should have a mindedness towards the fetal movement. So patient has to be assessed. If she comes with a decreased fetal movements, due regard to be given to the monitoring of the patient, and patient should be assessed by all the other parameters are to be assessed in detail, and active decision as per the findings of those parameters has to be taken. So it has to be given a lot of importance as far as prevention of stillbirth is concerned.
Absolutely. And ma'am, would you agree that one of the very important paradigms here would be to rule out FGR? Because like in this case, everything else was conducted, but a biometry per se, which could have said that this baby is small, was yet to be done when the baby actually developed intrauterine fetal demise. So while umbilical artery PI was done, while NST and biophysical were performed, biometry was a very crucial aspect. Would you agree, ma'am?
Yeah, totally.
So ma'am, how women with decreased fetal movements should be counseled? Ma'am Sumitra, please.
Good
Are
evening,
all of
and
them at a similar risk?
thank you, Dr. Jaya, for having me here on the panel. And I would like to, as already Dr. Sangeeta Gupta madam has emphasized, that when a lady comes to us with decreased fetal movements, it is like a red flag. And so it is like a red flag, and so we need to. Sorry, there's a lot of disturbance coming. So, when
I
we
think Dr.
analyze such
Seema,
women, hello.
Dr. Seema to be muted.
So we need to immediately, as a lady comes to us with decreased fetal movements, we have to, for counseling them first, beforehand, we need to know whether, it is a red flag, definitely. Almost 15 to 20% pregnancies do come to us with decreased fetal movements. Now, some of them may be low risk pregnancies and some of them may actually be high risk pregnancies. So we have to decide, as madam also said, that we need to take a clear cut history. We need to rule out the risk factors, blood pressure, diabetes, any autoimmune disorder, whether she's on any medications, whether there is history of fever, history of leakage, so all those things which are the risk factors. Once we've evaluated those, then we, of course, do a thorough examination. We know her vitals, we know her temperature, we know, whether we need to do an ultrasound and a CTG. So an ultrasound is paramount, and as you said that most of them can be small babies which we might otherwise have missed. So when we know and we can categorize her into two subsets, that this is a low risk woman and this is a high risk woman. So for a high risk woman, then there are associated comorbidities, and like IHCP, and somebody with IHCP coming in with reduced fetal movements, two red flags, I think. So so that way we need to counsel them that your pregnancy is very precious and you are having some high risk factors. So we need to keep you under observation. We need to do further monitoring, and according to
Can
the
you tell
period of
Dr. Seema
gestation.
Prakash to be muted?
So according to the period of gestation and the comorbidity that she's carrying, we need to take a call. And if it is a small baby, the Dopplers are affected, again, accordingly individualize the case and take a call. If it is a low risk pregnancy, we of course keep her under observation and everything is normal. Then we can reassure her. And we can keep her for some time, and if once she starts perceiving movements, and here I would like to say, movements they should be categorized like it's like a it's a roll, it's a swish. It is not just a simple flutter. So sometimes we just disregard and we say, of course ye to movement tumhe feel hua tha. So it is not like that. We need to be very clear about it, and she understands what actually her fetal movements are. And we can send back a lady who's a low risk pregnancy. But mind you, if a lady is coming back to us within 21 days, again with reduced fetal movements, even if it's a low risk pregnancy, we have to again, take a call and review the case. And here the importance of ultrasound is there, and of course the Dopplers and the Leica. Sometimes we have women who are low risk, they only have oligoamnios, and they don't actually end up feeling the fetal movements, and then oligoamnios becomes another cause of concern. So that's what I wanted to say, that for counseling we first need to know which subset they would fall under, and accordingly we will either reassure or we need to further take keep her under observation and take further action.
Precisely. That was one of the very important take-homes, that if a lady is coming to you with recurrent decreased fetal movements or with associated pathology like FGR, then they are a completely different subset over and above those who came just once and were found to be absolutely fine and low risk. Very well pointed out, ma'am. So can you just summarize this case first, Dr. Smith?
Okay. So this was a lady who had come to us initially, who was initially diagnosed to have, in the first antenatal visit itself, she was diagnosed to have GDM. So from that time only, we know that now she is into a high risk category, where gestational diabetes, which is associated with so many other adverse outcomes such as stillbirth, small babies, and later she may develop hypertension and even IHCP. So in these cases, we need to be these women need to also be counseled that one needs to serial monitoring, of course, and one needs to explain to them about fetal mindfulness, like how she should be comfortable and understand about the movements that her baby is making, and keep a close watch on it. And accordingly, if she presents with decreased fetal movements, as we discussed, that we have to have a very proactive, approach, and do all the necessary investigations, and then take a call that she is of course a high risk case, or accordingly at what period of gestation she's presented, and whether we should go in for termination, or we can keep her under close monitoring and then plan a termination.
Fair. Can I invite expert comments from Dr. Tamkeen Khan, please, on this case? Ma'am, could you please throw some
Yes,
light
I
on
must
what are we
congratulate
dealing
you,
with?
Dr. Jaya, for taking a very, very, complex case and discussing so many points at the same time. And this is what actually happens when you look at any stillbirth, you will not find a single factor. And that is why you have a triple cause theory, that there are certain maternal factors like age, obesity, smoking. And then there'll be certain placental factors like placental insufficiency. Then certain stressors like she's not sleeping on the side. So there's some venocaval compression, and maybe a genetic predisposition, a cardiogenetic factor. So all these together will combine. It's very difficult to pinpoint one single cause in most of the stillbirths. So we have to keep that in mind, because we have to prevent a recurrence. And that is the reason why not all factors are acting all the time. Sometimes you have a diabetic on insulin and absolutely uncontrolled and with a live baby. And you have one with mildly deranged sugars and not able to, the baby not able to survive. So that we need to, that has to be stressed, which your case has very, nicely projected. Another was, you were talking about metformin. Obviously, insulin is the drug of choice for controlling meticulously. But for our type of women, my cohort of women who are coming from very low resource setting with just 300 rupees, daily wages, not able to afford insulin or not able to store insulin, metformin serves as a very good drug. And for them to stick to a high protein, complex carbohydrate diet is also very difficult. Sometimes they are just on 2 meals a day. They can't afford those two small snacks and 3 meals. And that is why I'm very much worried about their insulin, because once I put them on insulin, more chances of them going into hypoglycemia if they're not sticking to it. So I find metformin much, much more convenient as compared to insulin for these kind of women. And then, of course, you were talking about GDM and FGR. So FGR is so much masked by uncontrolled diabetes that we miss it. So whenever we see a patient who's coming with polyhydramnios and then resolving on its own, a patient whose baby was at the 90th centile and then coming at 50th. So clinically, we are going to miss it. So I have made it a point that for all diabetics, at least one ultrasound, at least just before labor, around 36, 37 weeks, to know whether they are fit for labor or not. Because that uncontrolled diabetes will mask their, the projected weight was maybe 4.5 kg. Now it is 3.5 kg, and we are resting assured. So color Doppler has to be there for these women. So this is what I wanted to emphasize. And for reduced fetal movement, we have a very clear protocol from all guidelines. Any woman, whether low risk or high risk, it's a red flag, should be evaluated within 2 hours. Some guidelines say 30 minutes by a CTG. Some guidelines say 2 hours with a CTG, followed by ultrasound within 24 hours if it can wait, if the CTG is okay. And if the ultrasound was not done in the last 15 days. If it was done before that, you have to repeat the ultrasound as well. So that is an opportunity to work up that patient again, whether she's really high risk or not, or low risk, and then it should never be neglected. It has to be evaluated by CTG within 2 hours. Most of the guidelines say that. So thank you so much.
Okay, ma'am, I'll be greedy and I'll ask you one more question, ma'am. Ma'am, we talked about metformin. So, ma'am, what is the dose of metformin that you would choose to give to a woman who's coming to you with hyperglycemia in first trimester?
So usually I start with 500, because the moment we start metformin and then counseling and recounseling, they also, at the same time, it's a warning sign for the rest of the family members as well, because diabetes is always a diagnosis for the whole family. If they are not supporting her, she's not going to stick to the diet. So I usually start with 500 and then I increase it to 850. And usually I do it because when you see their patterns, they're absolutely erratic. There's no pattern. If somebody is coming with regularly only fasting hyperglycemia, maybe I'll put her just on, insulin at bedtime. But here they come with absolutely no pattern. जो भी घर में खाना है, whatever they उस दिन जो उनको
वो
मिल
मिलेगा।
गया तो वो खा रहे हैं. So
True that.
it's not safe to put them on insulin for the patients that I'm catering to. I'm not talking about in general. Absolutely, it is insulin which is the drug of choice according to all guidelines right now.
Very
So,
ground level reality.
can I put in, Jaya, just a
Very
little
welcome, ma'am. Please.
this
Yes.
thing? If you have a patient on insulin and her insulin requirement reduces suddenly, you should think of placental insufficiency then. So that
Very
is the baby which is at risk now because the insulin requirement has reduced. There is a placental insufficiency. That pregnancy needs to be monitored more. So that is another thing to remember. And as Dr. Sangeeta said, I think here it is more of this thing, multifactorial cause rather than just the
It
diabetes
is.
in this
It
patient.
is.
Yes.
Most
And
certainly, ma'am, and this was very important to point out what you
and
said that lowering of insulin requirement could again be a huge red flag.
And
Yes.
Ma'am,
Dr.
Sonia, you
Jaya,
were trying to say
like
something?
I would like to suggest after every stillbirth, we need to have an audit with the 3-4 minds and an experienced team evaluating the audit because it is always multifactorial. It is not just one thing which leads to the stillbirth. So
Absolutely.
we should have an audit of every stillbirth in our
Yeah.
institution by a team, maybe unit or maybe a fixed team or maybe the treating doctors along
Now,
with
this is the guideline also, ma'am. It's a government guideline that we have to have a stillbirth audit.
Yeah.
So I think all institutions are routinely performing it also. And like you said, it is the need of the hour. Absolutely, you can't. Yes, Namkeen ma'am, most certainly.
No. And it is better to include the patient or her attendant as well, because the lived experience and what she's telling you, the history is absolutely different from what has been recorded in the case sheet. Because she came, she went back, nobody looked after her, nobody listened to her for so many hours, or the ASHA worker did not. So all that has to come out. What were the 4 delays at home or whether it was at the hospital? And the quality of, the quality of care also cannot. Puri file ban jayegi and you won't know what is the cause unless you talk to the patient and her attendant.
Yeah,
Very
very
well said, ma'am.
very
That's a very important stakeholder who needs to be included, not just the multidisciplinary doctors panel that we keep for such audits. I think the
I
patient's story
agree
would
with
be very
doctor
different to that.
that these delays have to be taken care. These delays, as far as maternal mortality and as far as stillbirth, they are very, very important. We all have to understand the role of these 3 delay. And once a woman reaches to us with a good fetal movement, there should not be any cause that she goes home empty-handed. So these delays, may it be at any level has to be taken care.
Very well said, ma'am. Very, very well said.
Jaya,
So,
I'll
yes,
also
please.
be a bit greedy and just because there are so many senior people here, just a minute to one point that what kind of a tight glycemic control are you looking at? Because there will be times when she is going to become hypoglycemic. So what do the seniors say? Like there's so many senior people here. Like, do you think that any values which are more 30% values or more are deranged, only then you would change the insulin protocol, or would you look for a even tighter glycemic control?
Ma'am, as per recommendation, 5 to 10 milligram per deciliter of variations is acceptable. But if more than 30% of, like if we do a 6 point and 3 of them are deranged, then we should increase insulin. And we take a endocrinologist opinion always in
Of
our
course, we also
institute.
do that. I was just wondering, Tamkeen ma'am is there, like senior people are there. Like, would a tighter glycemic control make a difference, ma'am?
So there are a lot of studies.
So what is
which
your
say that
expert
too much tight
opinion?
cut is not going to help much, and it may even harm in some cases, like when she has a retinopathy already. So it's something,
Yeah, even I
Something
would
we
say,
have to
Dr.
keep
Smita,
balancing.
ma'am, that FGR can also be a flip side of too tighter
Yes, of
control. So
that.
one has
That's
to
what
be
I'm
very
saying.
mindful of. It's a
And
double-edged sword, I believe.
hypoglycemia is more dangerous.
It's worse actually for both the mother as well as the baby. Rachna ma'am very, very carefully pointed out.
I personally feel that too tight a control is not very practical either.
Yeah.
It's very difficult to maintain the same diet schedule at that particular time. And diet has a very important role. So usually when the sugars go haywire after a good control, one must really go back and revisit the diet of the patients, because I think it's very human to get fed up of a very strict schedule every day. And It's very
Right.
important to revisit the diet, I think, whenever, and it's, I think, not practical to have a very tight control all those long months.
Very, very difficult.
I'm very
Very
relatable.
difficult.
If someone was to ask me to remain famished for 9 months, it would be really difficult. So with that, I seek permission to proceed to the second case, please. This was a 32-year-old lady, a sixth gravida, para 4, living 1. Her 3 issues had died. 36 weeks and 2 days of pregnancy, she comes to us with a single raised BP record of 130 millimeters of mercury, and at 35 weeks, she had been diagnosed with late onset FGR. Her first trimester, it was a spontaneous conception. Her combined first trimester was low risk, OGTT was fine, she had taken folate. We had put her on Ecosprin 150 milligrams at 8 weeks and 5 days only, looking at the calculator that we had from the Fetal Medicine Foundation. Second trimester, level 2 suggested no GCA, OGTT was still fine, she was immunized. T3, she was on our radar because of her bad obstetric history, and with a single BP raised record 130/100, we admitted her. Her past history, she was a known case of hypothyroidism since 2 years on tablet Eltroxin, and that was well optimized. The family history was not significant. Her obs history is of a major concern to us. First pregnancy ended up as a 6 weeks spontaneous abortion. The second pregnancy, there was a term stillbirth, home delivery. The male baby was, as per what she suggested, 2.25 kgs, and that was a little below our standards as compared to what we would have expected this to be. No known comorbidities there. The third time she conceived, it was a full-term male delivered at a government hospital, 2.5 kgs this time. And the fourth time, she had a term male IUD, again delivered at 2.1 kgs, but no workup was offered. She was discharged the very next day from the facility. Fifth pregnancy is when we encountered her for the first time at RML. And she had a preterm, she came to us with an IUD, and there was a huge abruption there. And that is what had explained this particular IUD, and we delivered her. But we put her onto a lot of counseling to suggest that if you really want to conceive and have a good outcome, please come to us early on the next time. Do not come to us as late as what you've been in the previous pregnancies. So this time, what are the high risk factors for stillbirth in this case? Ma'am Sangeeta Gupta from ESI, please.
Now the high risk factors, just high risk factors in this case are previous stillbirths. So many previous stillbirths. They are very history of previous stillbirths. Then history of PIH in previous pregnancy.
Yes.
History of PIH in this pregnancy. So, I mean, it is very difficult to remember all the obstetric history given 1, 2, 3, 4, 5. But in these cases, there is so many high risk. Again, there is history of abruptio placentic, which, as Dr. Aparna said, that it can again be a thrombophilic disorder, which can be a cause in this case. So here Dr. Tamkeen and Dr. Agrawal are sitting here. I would like to suggest one thing, that why don't we have fetal safety score or a stillbirth score at every visit of the patient whenever she comes to us with in the first trimester, then she comes to us in the second trimester and subsequent visit. And we have to identify all the high risk score as per the high risk score chart made by us, so that we are not going to miss any high risk factor in any patient. And of course, about this patient, there are so many high risk factors, and we have to take them into consideration.
Absolutely.
Dr. Jaya, was she evaluated for APLA after 6 weeks?
Yeah, that's
She
what I
was
say,
negative.
thrombophilia.
Yeah, she was negative, ma'am.
She was negative.
She
Okay.
was negative. Since like this time we were very enthusiastic
So
that we have to, like, we were very committed that way, but it was negative, ma'am. We could not find a clear-cut idea as to what is leading to all of this.
Okay.
So
And there is
next
history of
is,
FGR also, very true, yeah.
yeah, we took the birth centiles because the earlier scans were not available. Like, she was not a very well followed up case otherwise. So
So
is there
I think
like,
except diabetes, all the high risk factors were there in this patient as far as
fortunately she was
main
not
factors for
diabetic, ma'am.
stillbirth are concerned.
Absolutely rightly pointed out. So like what Ma'am Sangeeta just now pointed out, do we really have a stillbirth calculator, Dr. Sumitra, to calculate the risk for ourselves and, you know, make life a
Yes.
little simple? I'm not sure if Dr. Sumitra, are you there?
Yeah,
Actually, Dr.
hello.
Sumitra, yeah,
Am I
hi.
audible?
Very
Hi.
much.
So,
Yeah.
regarding stillbirth calculators, Dr. Jaya, there was earlier, you know, when we were looking at some data and all, there was a calculator on the FMF site. which was
Yes.
using the 11 to 13 weeks data, which was looking at certain maternal demographics, various high risk factors, mean arterial pressure, BMI, and any other associated hypertension, diabetes, all that, and some placental biomarkers like PLGF
Yes.
and the uterine artery Doppler.
Yeah.
So there have been reported studies based on that they were giving us a risk for stillbirth for that pregnancy.
Yeah.
Recently, I don't know, maybe the website was revamped. We haven't been able to access that calculator. But there are various other studies also where there are various models that people have tried out. Various studies
Yeah.
have tried out different kind of models. Few of them are based on logistic regression, some on even using machine learning. But most of them are using similar data,
Yeah.
like the maternal demography, previous history of stillbirth, of course, current pregnancy, the maternal demography, any other associated risk factors, uterine artery Doppler, and biomarkers. So that way, there is no such an established calculator. They've all used their own models to, make an area under the curve. ROC, AU ROC, and they have given various cutoffs and they validated those cutoffs in their study saying that. So I suppose as a reference, currently I can't say that there is an established calculator, but we can in our own institutes or we can, use these various parameters to define a risk
Yeah.
in that lady.
Yeah, absolutely. The validation studies by
we
FMF
can.
have been very useful and they were very positive about the FMF risk calculator. That it does give you some very valuable bit of information. I don't know why they scrapped it, but yes, I think Delhi can come together and if possible, now you and me being in the Genetics and Fetal Medicine Committee of FOGSI, the entire country can come together and devise a protocol like that.
And I think Madam Neelam and Madam Thamkin are there, so we can, they can guide us that we should have our own calculator.
I know we all should have our own fetal safety score, which should be validated.
And what about PAPE? Doing PAPE as a adverse outcome measure?
No such.
Look, ma'am, there are studies to say that less than 0.5, 0.4 is something like a red flag, but consistently it has not come out to be very excellent insofar as correlating with outcomes is concerned. It's still a gray area. One
very
can
low
choose to put
sensitivity.
very low sensitivity.
As an individual marker, it performs very low to
yeah.
predict any adverse outcome. As an individual marker, it is only as a confluence of many markers that to its performance in aneuploidies of good value.
Thank you. I would like to add one thing that we should not forget severe anemia as far as stillbirth risk is concerned. So this is very common and very common presentation in government hospitals. So we all have to take care of anemia right from the early pregnancy for prevention of stillbirth.
Yeah, and in government, we also see RH isoimmunization as a cause of recurrent stillbirth, which has not been discussed today.
And as well as IHCP.
And we see it quite often.
Quite often we see it.
Yeah.
I hope not, ma'am, because RH isoimmunization, we've done a lot of work and we are doing intrauterine transfusions. So, I mean, really would be very sad that we are still losing babies in RH negative women.
Yeah.
Can I come in, Jaya?
Absolutely, ma'am.
Yeah.
Welcome.
So basically, regarding the calculator, we did a study in which we looked at the hypertensive women with stillbirth and we compared them with women who had live birth. And then we devised a sort of a regression formula in which we have put it in the Excel sheet. So in that we had socioeconomic status and it was like weight of the baby if less than 2000 grams and abruption. And apart from that, we had gestational hypertension. So we found that women with preeclampsia didn't had so much stillbirth compared to women with gestational hypertension or chronic hypertension. So we made this and we have published this also, but we have not actually proceeded further and validated it. We did that study and we found that it was good. And regarding PLGF, we have done studies on that. And PLGF has good sensitivity and specificity for, it was around 70% and with around 60-70% specificity that it could detect adverse fetal outcomes. and that
Right.
included stillbirth also. So it
Yeah.
was not PLGF later in pregnancy, but PLGF done in the first trimester that was found the best. So that paper is in communication. So in that we have done only stillbirths, compared it with in general population, and seen like we had around say 30 stillbirths in 1,000 women, and it was a small data, but still we found that PLGF was quite good, and split PLGF was good later in pregnancy. So this was what we found.
Ma'am, insofar as stillbirths are concerned, 1,030 are by no means a small number. So you have an excellent data to share and to publish.
1,000 women in which there were 30 stillbirths.
Yeah,
So
yeah.
the
So this is
stillbirth was actually less, but it was a prospective study, and we did a prospective analysis follow-up, and in that we found this. So it was a secondary analysis of the data that we were collecting for hypertension.
I think it is time for us to actually economize PLGF a little. It is time that we do not dig huge holes in the pockets of patients for getting it done. And somehow I think all of us together can,
It costs
pitch in
only
our
250 rupees. We have been doing at our center, and it costs only 250 rupees to do the
Ma'am,
test.
the private partners are not offering it for as reasonable a sum of money, ma'am, unfortunately. So until we
So
have
I think thing is that if you are doing Down syndrome screening at your place first trimester, then you can include PLGF also with it, and it gives a good
yeah,
value.
and that's an excellent test to actually offer in addition to the first trimester screening, ma'am. And that should be one take home from this panel, I believe. Thank you so much for that. That was really enlightening. So, is there a way to mitigate this risk, like we said? So, Dr. Sumitra, can you please take us through this? That we know that this lady had a lot of risk factors. She had preeclampsia in a previous pregnancy. She had growth restriction, also abruptio placenta. So, would you like to offer her something to mitigate this risk in this pregnancy?
So you've already very nicely depicted here, Jaya, that we can put in these parameters and find out the risk. And if it falls into the high risk category, we can start her on aspirin, 150 milligrams, which will, of course, has now a role in delaying the development of preeclampsia and delaying preterm preeclampsia as well, and even pushing it towards like more towards development of term preeclampsia. So that is very good, like 150. Only thing is that we need to counsel them that how they have to take it. There are very, very, very few contraindications for not starting one on aspirin. One of them is peptic ulcer, but otherwise they can all take it at night after meals, and they need to walk around a bit after taking that. So that is one thing, and we can keep them under monitoring, because we need to again see the Doppler.
Yeah.
Once we've done this, we need to again see the Doppler in midterm, and then keep her under monitoring, and we can continue till term. And
Right.
of course, rest of it we can always, if as Manisha said, that a split PLGF later on also has a role.
That
But
definitely
a
that
woman who's put on aspirin, probably, hopefully, unless and until she does develop hypertension, we can use a split PLGF to try it later. That
Yeah,
can be there.
our subsequent case we'll
Yes.
be discussing that aspect.
Okay.
But for this
Okay.
one, I just wanted
And
to highlight that if you see here, we don't have a CRL. We don't even have a uterine artery PI. We don't even have a mean arterial pressure there. We don't have any biomarkers. And still the software gives us some kind of a risk. So what I'm trying to suggest is that nobody can say, I did not have anything to come to a risk. You at least have a patient, you at least have some history. So with that, one can never absolve herself of saying that we could not do anything. We really have a lot to do in terms of and these are all available free of charge, like we all know. So then we just have to put our details into it and find out whether a patient is, qualifying to be eligible for this therapy. And it really has very few contraindications, like Dr. Sumitra just said. So how is late onset FGR likely to be diagnosed, Ma'am Manisha?
So again, like we can start from the history. So if the
Right.
history is suggestive that she had a previous smaller babies, then that would be one of the things. Then BMI, age. So everything, like patient sometimes says that I have been having fever or not been eating or anything. So the late onset FGR can take place anytime. So you have to be very vigilant with the history, and then the clinical examination, in which we have this symphysofungal height, which I think still holds, especially in our set of population. And symphysofungal height has to be put on a chart. Because it is not that 33 weeks is 33 centimeter. So it has to be, and it also helps us to, know the projectile, how it is going. So this is important and plus then we, of course, for definition, we have all these criterias in which we do a Doppler also. And then there is middle cerebral artery and the CPR, which is the middle cerebral artery by umbilical artery PI. And then there are charts. Generally, at our place, we have put up charts in the near the ultrasound machine so that we can refer to them and then give value. So if the values are not there, then we of course refer to them and take out the value. So generally, it is like if you're looking at the umbilical artery PI, it is around 1.2 or more than 1.2 is more than 95th centile. So that is there. So you go by this.
Very fair. So once we know that this lady has a past history of FGR, maybe late onset, maybe early, we can't be certain about that now. But yeah, we do have a clue that there was an element of placental insufficiency. So how do we offer surveillance to these cases? Ma'am Sangeeta Gupta from ESI, please.
So since this patient has got a very bad history and we need to get at least this baby life, I think we should admit this patient.
She was hospitalized.
So once we
36 weeks and
admit
2
the
days, she
patient and
hospitalized.
CTG, biophysical profile and Doppler should be done in this patient regularly. And whenever we find that there is problem with this color Doppler readings, we have to take decision in these cases, thinking that early decision should prevent the prematurity of the baby, because in everything we have to see this. So there is more role of CTG and NST in this case as compared to color Doppler. That's what I would, because it is a late onset FGR.
Very well said, ma'am. That would override any Doppler, like even if the Doppler is normal, but the NST is not reassuring or the biophysical score is not up to the mark, that would be an indication for termination of this pregnancy. That is very, very well pointed out. And that's exactly what we did here. So we had these longitudinal charts showing us the falling of AC and the falling of estimated fetal weight centiles. We had at 36 weeks and 3 days parameters that were less than the third centile. And we had a CPR, which was 9th centile. This was 36 weeks and 3 days that we had all of this. So we wanted to not terminate premature. So we wanted to take her to 37 weeks with this. So what are the indications of delivery in late onset FGR? Ma'am, Ratna Viswas, please.
Okay, so as you thought about 37 weeks, that is the time when we should electively do a induction for a late onset FGR not having any Doppler abnormalities, if everything is going on fine and there is no maternal problems as such. But if there is maternal problems like a preeclampsia or a hypertension, then it needs to be assessed and they need to be terminated depending on the maternal assessment earlier than 37 weeks. So there are two things in a late onset FGR which we monitor. That is the maternal indication and fetal well-being. These are the two important things. So maternal, any complications, that has to be monitored in the fetus. We need to monitor the fetal CTG, as has been said by everybody, that CTG is more relevant in a late onset rather than the uteroplacental insufficiency, but that could also be there. So we need to also do the Doppler. And if any Doppler findings are abnormal, we know the Doppler cutoffs, like if there is absent and if there is reversed. So we have to terminate earlier, 32 and 34 weeks and absent and this thing. But if it is not there, and we are monitoring the middle cerebral artery and the uterine artery, the umbilical artery PEI, CPR is more than 5th centile here. So we can also see this thing, umbilical artery PEI, if it is more than 95th centile earlier, we did not have any recommendations as such. But the recent 2024 RCOG guidelines, they're saying if it is more than 95 in a late onset FGR, then you need to terminate within 36 to 36 plus 6 weeks. if CTG and everything is fine. And another thing which they have said, which we do not have, is a computerized CTG, which can pick up the
Short-term variation.
microseconds
Yeah.
short-term variability. So the short-term variability, if it's less than 3 in between 32 to 34 weeks, then it is abnormal. And if it is less than 4.5 beyond 34, that is abnormal. So they said that is a better way to assess a late onset FGR, which unfortunately most of us do not have it. So that is the issue. But by and large, if to take a one sentence, this thing, if FGR late onset without any complications, terminate by 37 to 37 plus 6, because it is one of the most commonest cause of stillbirth in FGR.
Absolutely.
More than
Late
that
onset
present
FGR.
in the early FGR.
Very true, ma'am. Because it is difficult to diagnose in the first place.
Yes.
So which is
So,
why
Dr. Jaya, you have kept a very good case of late onset FGR as far as stillbirth is concerned. That
Ma'am,
is really,
90% of
really
my
good.
research is on late onset FGR because I'm very enthused about the fact that we can't pick it up. So I'm hell-bent upon picking it.
So another thing, what the recommendations are, that we should do a biometry, So routinely in our institute, we are doing a biometry around 35 weeks to pick up the late onset FGR, and another ultrasound at 39 weeks to see AFI and NST along with that, so that we know that this patient can go in an uncomplicated patient, that this patient can go up till 40 weeks. So that is what we are following in our institute.
So I'll share what we did here, ma'am, and that was useful bit of information that we kind of practiced, you can say. So we were admitting her at 36 weeks and 2 days. Every single day we would look at her NST and her biophysical because of the dreaded history she had. We had planned her for elective cesarean at 37 weeks, but our resident who used to do an NST biophysical was in the habit of doing an umbilical artery Doppler every single day. She would do it because वो डरी हुई थी कि मैं घर चली गई और IUD हो गया तो something will go wrong. So every Saturday 1 p.m. she did this umbilical artery Doppler, and until yesterday that umbilical artery Doppler was not showing any chances of AEDF. There were absolutely no signs like that. But one fine day she developed this AEDF, and that was 2 days prior to her elective termination that we had planned at 37 weeks. So we had to take her for an emergency cesarean, and Parov, there was MSL grade 1 and the Apgar was good. Again, this baby was 0.89 centile because earlier also we had seen less than third centile ka growth curve. But the baby is doing pretty well at 2.004 kgs. And this was one case to suggest that stillbirth, despite all the bad things that are happening in the history, can still be prevented. So, Ma'am Manisha, can you please summarize this one for us?
Yeah, so like in this case, we saw that aspirin prophylaxis was needed because she was having all those stillbirths and bad obstetric history. So we could have given, and hypertension also. So, and we have already discussed the dose and all. Then serial monitoring of growth was essential, is essential in any case which are high risk. So they say that after 28 weeks, you do a scan at 28, then you repeat it, and you must do it. So in high risk, you do start with from 28 weeks. And normally we assess risk at 28 also. And of course, the umbilical artery Doppler, that was key in this case, and the other thing that I wanted to just point out, that in late onset FGRs, even if we induce them and they go into labor, we have to be very, following up in the intrapartum period also, because they have a low threshold, and so they can, and they, it can lead to an intrapartum death. So that also look
Well,
into.
thank you so much, ma'am.
Dr.
Ma'am,
Jaya,
Neelam,
I just wanted to add for this particular patient,
Yes,
she
ma'am.
being such a high risk and with previous so many stillbirths and FGR and all, she was a candidate who should be put on a, serial biometry for growth monitoring and not by any other method. She should have a serial biometry from 28 weeks onwards at 4-weekly interval with Dopplers at every visit, and this biometry and Doppler surveillance would have increased as soon as there is any fall in her weight estimated weight centiles or any alteration in her Dopplers. Because with so many previous stillbirths and so much going on, she had no other way to be monitored. So surveillance will also be determined by what was her obstetric history, not just by what her current growth trajectory or her current blood pressure is.
True.
Very well pointed out. And history is of paramount importance. Absolutely right. Ma'am Neelam, can we invite your comments on this case, please? Ma'am Neelam, our expert, is with us tonight. Dr. Neelam Agrawal, ma'am, please.
I think ma'am is not there.
Tamkeen, ma'am, can we invite your comments in that case?
Okay. There was some suggestion, I think, to have a, a scoring system for stillbirth.
Yeah.
I think that I just want to say that the only way to prevent stillbirth is to start talking about stillbirths and to be aware, both the community, the patient, and ourselves. We offer Down syndrome screening. Risk is 1 in 800 to 1 in 1000 in India. We never talk. Even after 30 years of my practice, I'm not able to, introduce this subject. She's coming to me all happy in the first trimester for antenatal care. I'm not able to talk or discuss that there's a 1 in 70 chance that she may have a stillbirth with a rate of 14 per 1,000. So we will never talk about that there's one risk. Another thing I remember very clearly that I repeat that with all my residents, that about 15% of all pregnancies will experience a complication. But 85% of those complications will occur in the low risk pregnancy. It is not the high risk. So high risk is always a red flag for us. She's SLE, we know. She's already a chronic hypertensive, we know. She's a diabetic, we are also more careful. Most of the time we are losing babies in which we have this, false sense of security that she's low risk. She has malaria, and for India, it is all, modifiable factors. The low-hanging fruit for us is malaria, acute gastroenteritis. She's coming late. She's already in AKI with a big IUD, severe anemia, preeclampsia, eclampsia.
Yeah.
So all these, and I like the Pradhan Mantri Matritva, Abhiyan. What it does is that every time she comes to us, you have to categorize and recategorize. So it has to be an
That's why I was saying scoring.
It has to be every time categorized.
Every time.
To be aware of the factors, to tell her about the sleep position. And for this particular patient, FGR was a great, red flag. The risk of stillbirth in previous FGR is more than in a patient who had a previous stillbirth. So previous FGR is definitely a very high risk factor for, stillbirth in the next pregnancy. So that is what I wanted to say. That
Dr. Jay, I would like to add my sentence here, that stillbirth risk is dynamic. So we have to reassess it every time. We have to rescore or recategorize the patient every time. And we have to respond according to that particular day risk assessment of that patient. So we have to be really stillbirth minded, that how to prevent this stillbirth. How to prevent stillbirth in this patient. We have to have stillbirth mindedness. Then only we can decrease or bring down the figure to less than 10.
So when the official data is 1 in 14, the risk is 1 in 70 at the start of pregnancy itself. The risk for Down is 1 in 800 to 1 in 1000. So just compare with that we are not talking stillbirth. So I'm really thankful to Dr.
I totally agree.
And to all of you that we all started talking stillbirths.
Yeah.
We have to think ourselves that which warning signs we ignored, where did we fall, because it is a failure of health system. And nobody uses a stillbirth indicator as the quality indicator for a health system. We have to now assessing the health indicator, quality indicator for health institution. We have to know their stillbirth number.
Absolutely, ma'am. So with this, we will come to a brief third case, and we will go through it very, very quickly because of the time that is running past. So we had this 43-year-old lady, a third gravida, para 1 living 0, aborter 1, 27 weeks of 5 days of pregnancy. She is a DADC twin pregnancy. She is an IVF conception with donor gametes. She was admitted with us for preeclampsia with severe features and a fetal growth discordance of 21%. There was a complaint of epigastric pain and difficulty in breathing. Before I go to the trimester history, it would be of importance to relate her OBS history with us. She had first come to RML as a priming gravida, 2018, an IVF conception, again donor gametes. This was a male baby, 475 grams, less than 5th centile at 24 weeks. So we saw that baby going right in front of our eyes at AADF, REDF, but we counseled her against an intervention because of the extremely low birth weight and extreme prematurity. The second pregnancy, she was a wee bit better at 28 weeks and 3 days, but yet the baby weight was just a little over 500 grams. So we still had to say that, we can't intervene. Every time she came to us at around 24 weeks. So we had very little to offer, except for hope that if you come sooner, maybe we can help you. 43 years was going against us. DADC twin was compounding the matter, and of course, an IVF conception. So, Dr. Veronica, aneuploidy screening in this case can be a challenge. She is IVF, she's donor gametes, she's twins, she's also advanced maternal age. So can you please help us understand what we can do for aneuploidy screening in this case?
Thank you, ma'am. So, ma'am, I understand she's 43 years of age, right?
Yes.
Okay, so she's 43 years of age with IVF pregnancy. We know that when a person is more than 40 years of age, the risk is more than a high risk on dual markers. So we offer better aneuploidy screening like NIPS or amniocentesis. In this case, because the pregnancy is so precious, we can offer NIPS. NIPS now is validated and fares as well as singletons as for twins, so we can offer NIPS here. In addition, I would also like to do the karyotype at least of the father, because we have a donor germ cell, and if in this case we have donor gametes, but still I would prefer NIPS in above dual marker for aneuploidy screening, because we have a twin pregnancy with a history of previous bad obstetric history. So that's why I would go for NIPS here.
Fair. So in this case, we offered her a combined first trimester initially, and this turned out that the second baby had the nasal bone absent. The first one was absolutely okay. So given that kind of an idea, the fetus B was high risk for down. And since she would not let us put a needle inside, so an NIPS was offered, like you said, and it turned out to be low risk. Her OGTT was fine. She was put on ecosprin 150 milligrams in the first trimester itself, and also on progesterone support. Second trimester, the anomaly scan was fine. The discordance between babies was just 7%. Again, no sugars abnormal. Gestational hypertension started. We were anticipating it so much actually. And so low rate 100 mg PD was started since 14 weeks. Her UPCR at that moment did not qualify for preeclampsia. The supplements continued. And based on the RCOG criteria, we started off with Clexane at 0.6 milligram OD on prophylactic doses. And her BP monitoring, of course, continued. And here the total score for her antenatally was 4. And therefore, we should have ideally started in the first trimester, but we did in second. So how do you monitor a DADC pregnancy, and what do you look for in each visit? Ma'am Sangeeta Gupta from MAMC, please.
So if you're talking about the mother,
yes, ma'am,
from the maternal and from the fetal perspective, we have to monitor both. Now, we all know that a DADC pregnancy has to be followed up every 4 weekly. After, say, first she's going to have a first trimester visit, then an anomaly scan between somewhere 20 to 22 or 18 to 22. And then she has to be followed up 4 weekly. And as for any patient, first trimester, you've already given us GTTs and everything. In her second visit, this mother has to be very closely watched for her blood pressures, what's her weight gain, and for fetus, the monitoring, there's no other way to monitor the growth of these fetuses except biometry. And along with the biometry in the second trimester, in the anomaly scan, we have to do a cervical length also, preferably by transvaginal route, and amniotic fluid assessment, and of course, detailed anomaly, and we are going to look for the placental localization as well, even at this visit. And in the subsequent visit, which will be another 4 weeks, it's the time to repeat her OGTT again. She's anyway going to be on monitoring for her BP. I would rather put the woman at a home BP chart with her age and her background of twins and an IVF pregnancy with so many things in the background. And this lady also having very early onset FGR in the last pregnancy. So at every visit, we are going to, and we will also start doing her Dopplers, particular in the second, in the anomaly scan, we could have added a uterine artery Doppler. Nevertheless, I think a uterine artery Doppler is not going to make much of a difference in the management in this case. From 24 weeks onwards, we'll put her on an umbilical artery Doppler also, besides a biometry, her amniotic fluids and everything. And a very intensive monitoring for the mother is required. And when we do the biometry in twins, we must always remember that we have to calculate the discordance as well. So it's not just FGR per se with a definition of less than 3 centile or a less than 10 centile will abnormal umbilical artery, but it's very important at every visit to calculate the discordance and label it. And this discordance should also be plotted serially. In case there is any increase in the discordance, that is also a red flag.
Absolutely, ma'am. That's one take home I learned from you in our previous interactions. You told me that I should be marking with a red and a blue pen on the same graph to be able to know discordance. And that is exactly how I've done it over the past so many years learning from you. So like I said, every time I come across a panel, it's my time to learn, and yet again, some pearls of wisdom, Mom. So this is what we followed up was a 0% discordance in the first trimester, 7% in the second, and 21% in the third trimester. In fact, not even third, it's late second, that 25 weeks, the discordance was 21%. At 27 weeks and 5 days, a 190 and 100 millimeters of mercury BP, we were actually anticipating something like this, given our past history. Her UPCR had now qualified for a superimposed preeclampsia. So she was stabilized with ivalabetalol, Mexel, furosemide because of this pulmonary edema component also that she had, and antenatal corticosteroids. However, she developed eclampsia and HELP at 29 weeks and 1 day. So we had to take her for an emergency cesarean. And there was some uterine artery tear because the lower segment was not very well formed. So we had to address that part. Everything was managed concurrently. The mother went finally to the ICU, where she developed postpartum eclampsia also on day 1. She had to be put on the nitroglycerin drip because ivalabetalol, etc., could not control it. The babies, twin A was 1148 grams, developed blepharoconjunctivitis, early onset neonatal sepsis, and also feeding intolerance. The baby boy, 980 grams, developed similar complications, but in addition, also metabolic bone disease. The good part is that after all the battles that she fought, of course, with us, after 45 days, both the babies and the mother was discharged in good condition from our hospital. So what are the preventable causes of stillbirth? Ma'am Rachna, please.
You want for this case or in general? Because
Ma'am, now it is
throughout the
general because
beginning we have been discussing this only. So
ma'am, you can
preventive,
take the liberty of taking it through the way you like it, ma'am. It's
yeah.
absolutely open.
So I think preventive every stillbirth except the genetically malformed babies, which are not preventable, but we can say preventable if their diabetes is controlled or they have a folic acid supplementation. So all maternal factors are preventable. Preconception period optimization of the mother can prevent stillbirth. Then screening, a good screening with a good history, biochemistry, and aid of uterine artery Doppler, PLGF. That would be the screening part, first trimester, to have a tight screening protocol. And then second trimester, a good fetal surveillance along with maternal surveillance. Not to forget the symphysis fundal height being seen by our residents to pick up the low risk cases. That is for low risk cases. And then this late onset FGR, which was very well highlighted, doing ultrasound at 35 weeks and again at 39 weeks. And then the most important, which was I think 40 to 50% are intrapartum stillbirths. And these are the very sorry ones, and these are the preventable. So induction of methods which are being used, the judicious use of intrapartum inducing methods, judicious use of monitoring. We have to triage in our labor room, like which case needs more close, because we know we cannot exactly monitor everybody half an hour interval. So we need to triage in the labor room and decide which exactly needs very close monitoring and which can be seen at 1 hour. And so to prevent the intrapartum stillbirth would be should be the goal, besides doing the antenatal part also. And I think everything is preventable. And
That is a
anemia,
very
not to
positive note.
yeah, anemia is the one. GDM is the one.
It starts with the mother, ma'am. You're very right in
Yeah.
saying that very
So
basic things.
Jay, I just wanted to say something once
Yes, ma'am.
Rachna has brought
yeah,
up
I'm through.
the issue of intrapartum stillbirths. I
Yeah.
think, avoiding unnecessary inductions
Yeah.
and
Yeah.
judicious
Absolutely,
use
ma'am.
of oxytocin.
Absolutely,
Judicious use
ma'am.
of oxytocin is very, very crucial. And
Crucial.
Lakshya has come up in a big way in laying guidelines on that front.
Yeah.
Yes, indeed, ma'am. Indeed. These
Not
are things that we miss out on. We look at the bigger things and we forget the very basic things as to at what rate is the syntocinon running in our labor rooms by our residents is something we tend to overlook. So this is so very, very meticulously pointed out.
Ma'am
Thank you for
wants to
that.
say something. Yes, ma'am.
I think I would second that, Dr. Sangeeta.
Yeah.
Most useful drug and most dangerous drug is oxytocin. And on top of that, now we have misoprostol, which is even, I think,
Madam, the
Even
point
more.
is that I think Lakshya has laid it down so beautifully that no woman should be induced or augmented unless there is a clear and definite indication.
Yeah.
So that's very important. Oxytocin is both a boon and a bane.
Yeah.
I think demedicalizing pregnancy is the best thing we can do to pregnancy in most cases.
I think
They
we
can
all
rather
are
do better
government
without us.
hospital doctors who are discussing these points here. But certainly the point of view or the viewpoint of private practitioners is different as far as these decisions are concerned. So we all are here, we are seeing the patient from a point of view of government sector. So
ma'am,
maybe the opinion of
ma'am,
private
but I
sector
think
differs.
our colleagues, we should also put ourselves in their shoes with the crunch of manpower and with the stress of having a medico legal
Yeah.
litigation. I think they are also pushed to a corner to take certain decisions.
Or that's why even in the government hospitals, our cesarean rate is increasing. And
Absolutely.
I think we all agree that if we increase the cesarean rate, there is decrease in stillbirth rate.
No,
What
I
is
will
your
not
comment,
agree.
Dr. Sangeeta?
No, ma'am. No, ma'am. I
Yeah,
won't.
that's why I raised this question.
This is another debate day, ma'am.
Yeah, ma'am, we are already very much overshot the time, and I think it is only the faculty
I agree.
which is
So I
attending
think
the
all the
panel.
messages should now be conveyed by Dr. Jaya only,
my
rather than
next slide is
taking the.
my next slide
So
is this,
question
ma'am.
you.
So, ma'am, Sangeeta, can we start from you? Sangeeta Gupta, ma'am, from MAMC, please.
I think I have given my message already that we should have a very, conservative use of oxytocin for induction and augmentation of labor for prevention of intrapartum stillbirths and particularly scarred uterus. The skill of VBAC is perishing, and so is the good use of oxytocin in women.
Dr. Sangeeta, you will be surprised. In AICOG, I had to take a panel on induction of labor. And when I told about VBAC, all the private practitioners literally rose up to say that there is no role of VBAC. Like it was difficult to convince them that VBAC exists in India and we are doing it. So that is the time now.
That challenge is there now. That is why, Dr. Rachna, we are operating 2 to 3 Acrita
Two to
every
three
week.
Acritas, yes,
Every
same
week.
here.
Not
And now
just every month,
Acritas
every
coming
week.
at 18 weeks. 18 weeks also.
Not only Acritas, we are dealing with the complications of cesarean done at other hospitals and being referred in a difficult situation to government hospitals.
Yes.
And ma'am, the number of scar ectopics which I am reducing nowadays
Yeah.
is also gradually increasing.
Dr. Manisha,
I totally agree.
Yes.
you can also say something.
So basically, I want to say that the first step in reducing is like what we have done is start the auditing. So we have seen at our place, like we started auditing around say 8 years ago, and it has really reduced. So we do meetings every Saturday, and we look into each and every stillbirth. and that has of course reduced. And then the other thing is try and see what are the factors that would be, that we can do. So what are the low hanging fruits at our place, and try to improve. So there's no use in only counting. You have to act on it and try to see where you can improve upon. So I think in our place we started with 30 per month, and now we are having it around, say, 10 to 12 per month. So we
Very
have really reduced. But yes, ma'am, you're right that we have the cesarean rates have improved, have increased since we have started this audit also. So it has impacted the cesarean rate at our
It
place.
directly correlates that intrapartum
yes.
stillbirth rate is 50%. So that's all we are agreeing, that intrapartum stillbirth
So our
caused is
intrapartum
50%.
stillbirth has been reduced to around, say, 20 to 25%.
Yeah. So that's why, because it has been reduced, because number of cesarean has increased. So there is no partum, no stillbirth.
True.
So
Not
my take-home
necessarily.
message, Dr.
Before I
Jaya
would
and
explain that.
other panelists, my take-home message will be that risk stratification or fetal safety score or stillbirth score should be done at every visit, and it should be a dynamic score, that the score should be changed as per the findings in the next visit, and decision of delivery or of admission of the patient to the hospital should be taken based on these fetal safety score. This is my one line saying to all the panelists and all the audience who are hearing.
So can we have a concluding remarks from our three more panelists that we have, Dr. Sumitra Bachani, Dr. Ratna Biswas? Ma'am, please.
Dr. Jaya, I would like to say just one thing, that of course during pregnancy, early detection of risk factors, taking care of the woman, what we are doing is that we are running a preconception clinic. So anybody who had a problem in a pregnancy, she had an abortion, she had hypertension, she had diabetes, and if there was a previous stillbirth, or if she is a nullipara, she is just planning a pregnancy, we're encouraging them to come to our preconception clinic and counseling them about that pregnancy is not just a simple unplanned kind of a thing you can go ahead with, because there can be many repercussions. So with that, we have seen that there are more and more women coming to us in the preconception, and we are screening them, and we are offering them counseling, and we are encouraging them to have a planned pregnancy. So that's what we
Very
think
clear,
that
very
really
clear. I think
makes
that
a
will go a long
difference.
way. Yeah. And Ma'am Ratna Biswas, please. Ma'am Ratna Biswas, please.
Yeah, so I think most of it is covered. Like we need to start early on, screen well from the first trimester itself. And for that, I would say that we should actually include our residents in the meeting, which we are usually not, because most of the time the history is taken by the residents, the first visit, and many things are missed, which is later picked up. So, I mean, we have to have these interactions with our PGs and SRs time on again, because they are the ones who can make a difference. There's such a huge population of antenatal women we are catering to, so they have to be. Most of the faculty do discuss, but I think it is missing at the lower level, so that has to be improved. For induction, I think judicious induction is, yes, necessary. Like, but when we have always to balance the risk, sometimes we see a lot of in my place at LHMC, we see a lot of IUDs which we are auditing is due to ISCP. So even with when the thresholds are not 100 and we are losing babies, with ISCP. So in that, the induction is also sometimes done at 37, 38 weeks, earlier inductions. So we have to balance between the two, whether to do inductions late, as they are saying, at the risk of having IUD. Like that is to be weighed. Another thing, induction with syntocinon may not be always so problematic if you are using the infusion pumps nowadays. We have infusion pumps, so nothing to worry, There the rates are not going to go high, but you have to monitor the labor. That is there. And the VBAC, it is very dismal. We have an audit every month, I'll tell you. VBAC in our place is 30% is VBAC, 70 is going for a repeat cesarean. In West, it is 70% is vaginal, and 30 is going for repeat cesarean. So it is dismal, you know. But then our situations, we are so cramped up, so many women, so much overcrowding in the labor room. So I think we need to actually have support with the staff which we are being provided, the nursing staff and all that. The Lakshya is there, but Lakshya, we have need the number of manpower is also has to be increased, you know. So I think it has to be at all level, multi-pronged approach to give the optimal care at every level. That is my take on it.
I second Dr.
Veronica.
Ratna.
Yeah,
I second Dr. Ratna.
great, ma'am. Dr. Veronica. Dr. Veronica, are you with
Thank
us?
you, ma'am. Yes, ma'am.
Yeah,
Yes, ma'am.
yeah,
I'm here.
please.
Thank you, ma'am, for a really immersive panel. I myself learned so much. Just my 2 cents that we should always keep the genetic factor in mind in addition to the maternal and the placental factor. It is our responsibility to take a short a family history, a pedigree analysis that gives us more information than we would expect. Also, maybe do an ECG of the couple to pick up disorders like long QT syndrome, which also can cause stillbirths. So, thinking genetic, even in the first stillbirth, goes long way, especially in preventing it. Thank you so much for having me, ma'am, and thank you, Patel sir, for this opportunity.
Thank you, Dr. Veronica, for joining us. Thank you, everybody else, for joining us. Ma'am Tamkeen, we would like to have your remarks before we conclude this session, and that would be so, so important.
So I think I would just like to thank Dr. Patel for a wonderful panel and Dr. Jaya. Your cases were really, complex and so challenging. 3 hours, I've really enjoyed myself the last 3 hours. Earlier also, Dr. Aparna and Dr. Upma, they spoke so well and they covered the topic so well. So I think the best for us at stillbirth is that everybody started talking about stillbirth. That was the first step.
Yeah.
And then we need to count the stillbirths. And then we need to, think about the low-hanging fruit. That is simple causes like that have been discussed today, that we don't miss them. And of course, audit is so important. So thank you so much. And now I'm so happy to see that every conference now has a session dedicated to stillbirth. So I think all of us working together will be able to do it. And thank you for, putting up all that IEC material from the SBSI.
I would just
All
like
the
to
very
share
best to
that
Dr. Patel.
this is the panel that I have.
Big
And
round
the
of
panelists
applause
were
for
wonderful, like wonderful panelists. Great to see Veronica and Dr. Manisha and Dr. Jaya. Your cases were really good. Dr. Sangeeta.
So big round of applause for Dr. Jaya Chawla, madam, for moderating this panel very nicely.
Very nicely.
And all the panelists putting their inputs about subject, and Tamkeen Khan, madam, especially giving your expert comments during panel, making this panel memorable and fruitful, I would say. So, Monica, should we conclude?
Yeah.
Sure, sir.
I would just take a moment to share here, sir, that this particular pair of babies, the boy and the girl that this lady had at 43 years, this family makes it a point to share their birthday invite with me every year. And that is one of the things that makes life a little more beautiful for, I think, all of us. Cases like this. But yes, thank you so very much for
and best wishes to
joining us for this.
both
Thank
the
you.
child.
Yes.
Thank you. Thank you, each one of my panelists. Thank you, Ma'am Tamkeen Khan, for just being there to show us the way. Thank you, Patel, sir, for entrusting us with this responsibility. Thank you so very much, Patel, sir.
Thank you, Dr. Jaya. Thank you,
Thank
Dr.
you,
Patel.
everyone. Thank you, Patel, sir. Thank you so much for having
Thank you,
me.
everyone, for joining us for an excellent panel discussion. At the onset, let us thank our chief guest, Dr. Alka Kriplani, madam, our guest of honors, Dr. Pratima Mittal, madam, and Dr. Ashok Kumar, sir. Our speakers, Dr. Aparna Sharma and Dr. Upma Saxena, Dr. MC Patel, sir. Our chairpersons, Dr. Deepa Gupta, Dr. Kiran Chabra, Dr. Seema Prakash, Dr. Vandana Gupta, Dr. Anita Rajoria, Dr. Sandeep Talwar, Dr. Panchampreet Kaur, Dr. Preeti Gaur, and Dr. Renu Chawla. The panel discussion had a lot of take-home messages for all the delegates who have joined us today. Thank you, Dr. Jaya, for putting in so much of efforts and getting the best of all the panelists. Our experts, Dr. Neelam Agarwal, madam, and Professor Tamkeen Khan, ma'am. Our panelists, Dr. Manisha Kumar, Dr. Rachna Agarwal, Dr. Ratna Biswas, Dr. Veronica Arora,
Dr. Sangeeta Gupta, Dr. Sumitra Bachani, and Dr. Sangeeta Gupta. Thank you so much, everybody, and thank you, Corona Remedies, for the academic platform. Last but not the least, thank you, Dr. Patel, sir, for the opportunity to coordinate, and wishing you all the very best for all the future endeavors.
Thank you. Thank you. Thank you.
And please vote and support MC Patel, sir, for his presidential candidature.
Definitely. All the best.
Definitely, definitely.
Thank you. Thank you.
Thank you so much, everyone.
So
Thank you.
we had a full attendance from Delhi, 100 out of 100. Everybody.
Wow.
And we got vote also 100 out of 100.
Wow.
Yes.
It was, I think, one of the best webinars of Happy Learning. That is what I feel.
So
I
in
think
the Rajasthan attendance was very good.
Yeah, apart, the academics as the attendance as well. One of the best. I didn't say the best. I said one of the best.
And requesting everybody to
you so
be
much.
members of the Esteem
Yeah,
India.
thank you so much.
2,500 is life membership.
ठीक है ma'am.
Thank you. We will become the members.
Yes, ma'am. We will, ma'am. Please share the app is
I put the link on the group.
Yes, ma'am.
Yeah,
Yes, ma'am.
I'll
Yes,
put
ma'am.
the link.
Yes, ma'am. Definitely, we will join.
Thank you so much.
Thank you, ma'am. Thank you.
Madam, in this group, you put the link.
Yes.
So response will be there.
Okay, thank you.
Definitely.
I am already member.
Yeah.
Have to member next time.
We are honored to have you.
Yes.
Bye.
Thank you, ma'am.
Okay. Okay.
Thank you,
Now
sir.
we
Thank you
can
so much,
conclude.
everyone.
Thank you.
Thank you
Thank
so
you very much.
Excellent panel discussion.
Yes.
Thank you.
Thank you, Dr. Ritik. Thanks to all our panelists.
Yeah.
They were really, really wonderful. True to the word.
And the Delhi is known for the academics.
Yeah, that is what I found. In every conference, the house is always full. Even in AICOG, I saw
Yes.
that all the halls were full.
Yes.
That was true. That is there. And
All
you
our panelists have
had all
given
head
us so
of
much to learn.
departments, all senior professors, head of departments of all the medical colleges were there on your panel. So,
Dr. Logani, it's their greatness. They accepted to be a part of it. It's totally their greatness.
Yeah.
And I am profoundly thankful to each one of them in person.
Exactly.
I have had so much to learn from all of them.
Yes, that is true.
Yeah, you are a very well coordinator and a very well moderator. और बहुत प्यार से तुमने हम सबको इकट्ठा जोड़ के आज इस पैनल को किया है. Thanks a
मैं
lot,
सिर्फ शुक्रगुजार हो सकती हूँ मैम. यहाँ पे जितने भी हैं मेरे सीनियर्स हैं. Thank you very much for accepting to be a part of this, madam.
बट डॉक्टर सूत्रधार जो होता है वो बहुत इंपॉर्टेंट है. सो आपने जिस तरह से आप इतने सच्ची में जैसे मैम बता रही है इतने प्यार से यू आस्क द क्वेश्चंस एंड यू मॉडरेटेड द पैनल गिविंग रिस्पेक्ट फुल रिस्पेक्ट टू एवरीबॉडी.
रानी मैम ये दिल से है क्योंकि इतने सालों का एसोसिएशन है.
Yes.
इनमें से हर एक के लिए मैं बता सकती हूँ कि मैंने उनसे क्या सीखा हुआ है.
Yes, I can.
They have been the ones who have paved my way for decades now.
Yes. पर आपका पैनल डिस्कशन एंड द केसेस एंड they were just excellent.
Thank you. Thank you so very much. Coming from all of you, that means a lot. Thank
So it is almost 10 o'clock now.
Yeah. Thank you.
It was
We have
fine.
to conclude.
Thank you, ma'am.
Corona friends, we can conclude.
Yeah. Thank you.
Thank you.
Good night.
Good night.
Good night.